हर साल की तरह इंडियन विमेन्स चैरिटी फंक्शन सी अपनी डायरी शायरी में लिखते ओके लिख लूंगा आई सी यू बाय बाय जा रहे हो
ఎవరు తీసుకున్నారని చెప్పింది మొన్నే. ఆవిడ కాటనే కడతారు ఎక్కువ, కాటన్ చీరలో పెట్టుకుందమ్మా.
ఇప్పుడు అమెరికా వెళ్ళడం లేదు మీరు?
అవును, నీకు వేసే ఎప్పటి వరకు ఉంది?
28 వరకు అన్నప్పుడు లేదు కదండి, 6 నెలల వరకు వెళ్ళడం లేదండి.
అలా ఏం లేదు. వెళ్ళాలంటే వెళ్ళొచ్చు.
కతార్ వెళ్ళి కతార్ నుంచి వెళ్ళడం ఈజీ. వదిలి కూడా నాకెళ్ళడం కతార్ అయితే అని అనుకున్నాను.
ఇద్దరం కలిసానే అనుకున్నాము.
కతార్ వెళ్ళి నేను అటు నుంచి వెళ్తాను, అలా వెళ్ళిపోతాను, తిరిగి వెనక్కి వచ్చేస్తాను.
మధ్యలో ప్రోగ్రామ్
చూద్దాంలే జ్యోతి, ఒకవేళ లేట్ అయింది అనుకో అప్పుడు కుదురుతాలాగే చేద్దాం. నేను నీతో వచ్చేస్తాను. నాకు ఇప్పుడే వెళ్ళాలని ఉంది. జూన్ జూలై అంటే పిల్లలు సెలవులని. జూలై ఫస్ట్ వీక్ అలా వెళ్ళినా చాలు, ఒక నెల.
వచ్చే సంవత్సరం వెళ్ళండి. గోదావరి పుష్కరాలు ఉన్నాయని ఈ సంవత్సరం వస్తానని చెప్పారు. మీరు ఎక్కడికైనా వెళ్తే కుండలేశ్వరం ఎక్కడికైనా వెళ్తే మీతో పాటు వస్తాను.
అక్కడ త్రివేణి సంఘం ఉంది గదిలో, అక్కడ కుండేశ్వరం
అంతర్వేది చేయరు కదా.
నేను ఇవాళ ఏదో చదివానండి, ఒక కాలభైరవ టెంపుల్ రాశాను. యానం దగ్గర నుంచి జీ మూలపేట, అక్కడికి వెళ్ళి అక్కడి నుంచి బోట్లో వెళ్ళాలి. కాలభైరవుడు భైరవపాల్ మాది, ఇంకేదో పేరు రాశాడు.
నిజంగా
తెలిసిపోయింది కోడలు. వాళ్ళు అన్నదమ్ములండి వీళ్ళిద్దరికి కొడుకులు అన్నమాట. అమితాబ్ బచ్చన్ వాళ్ళకి చిన్నప్పుడు ఏదో పట్టుదల కోసం వాడు ఇల్లు వదిలి వచ్చేస్తాడు. ఇప్పుడు వీడు కూడా తెలిసిపోయాడు. అడిగి తెలీదు మరి, ఆడు నొప్పించాలిగా. ఇప్పుడు ఆడు పంతంగా వచ్చేసాడు కదా. ఇప్పుడు పిలిపిస్తారు, లండన్ వెళ్తారు వాళ్ళిద్దరు.
శ్రీశైలం కూడా ఏంటేసానండి జనవరి 8 స్పర్శ దర్శనం, మళ్ళీ ఇంకో దర్శనం 2 సార్లు చేయించుకున్నాడు. స్పర్శ దర్శనం కాదు కదా వదిన,
ఉంది అనుకుంటా. స్ఫటికలింగం ఈ వాటర్ మాత్రం పోయినవాడట వేరే చోట. అదే మనం ఇలా తీసుకెళ్తేనే. నా దగ్గర ఉన్నాయి కదా జ్యోతి, అదే పోద్దాం. నువ్వు తెప్పించావు, అదో బాటిల్ ఇచ్చావు, అందరు కలిసి కొంచెం కొంచెం వేస్తాం. ఇవిడ అమెజాన్ లో తెప్పించింది గంగాజలం, అమెజాన్ లో వచ్చినాయి.
ప్రయాణ
अच्छा ये बात
మీ దగ్గర ఇలా రాయి చెట్టు లేవా? రాజు అవి పట్టుకోండి, ఎందుకని మంచిది, అవి పట్టుకోండి. ఆ చెంపు నీళ్ళు తిప్పేసి వేసుకోవచ్చు, ఇంట్లో ఉంటే పట్టుకోండి.
రాగి చెంప కాదు, సీలేసిన వాటర్.
కాసింది తెచ్చిస్తారు కదా,
లేవా మీ దగ్గర?
అడుగుతాను, దీని దగ్గర ఉంటాయండి, ఉంటే దాని దగ్గర ఉంటాయండి.
ఒక చెంపు పట్టుకున్నాం, ఇద్దరు చాలు, ఇద్దరు కలిపి వేసుకోవచ్చు.
वाह वाह राम जी जोड़ी क्या बनाई What? भैया और भाभी को बधाई हो बधाई वाह वाह राम जी जोड़ी क्या बनाई भैया और भाभी को बधाई हो बधाई सपनों से बड़ी है जग में दिल से दिल की सगाई वाह वाह राम जी जोड़ी क्या बनाई भैया और भाभी को बधाई हो बधाई
అవి పట్టుకోండి కూడా.
వాడి వేలు చూడు ఎలా కనిపిస్తుందో.
డెకరేషన్ బాగుంది.
మరి అలాంటివే తీసుకుంటారు, ఇవన్నీ మ్యూజియంస్. రాత్రి భోంచేసి కూర్చొని చూడాలి సినిమా, అప్పుడు బాగుంటుంది. రిలాక్స్ గా
కాదు, వాళ్ళ పాపం పట్టండి,
రాని వచ్చిన దాన్ని బట్టి
అమావాస్య కదా రేపు,
అందరూ పండగ హడావుడిలో ఉంటారు.
దానికి అమావాస్య
10th క్లాస్ ఎగ్జామ్స్ ఒకటి అయిపోయినట్టున్నాయి, వాళ్ళతో అయిపోయినట్టున్నాయి. మన రేపు తెచ్చుకుంటామా పూజ సామాన్. Yeah, good evening, madam. Nirmala, madam. How are you, madam?
Thank you. How are you doing, ma'am?
Fine, madam.
It's like
Fine, madam. So you are coming to Ongol, madam?
not yet decided. I'll be on tour.
Yeah. Hi, Lalita.
Madam, hi madam. Good evening.
Hi, Monica.
Good evening, ma'am. How are you?
Fine, fine. I think you are busy for the past 3 days with the mocks.
Just finished with Amav's ma'am. Now clearing the backlog of the OPD. Nirmala ma'am, good evening.
Yeah, madam, Dr. Umashankar sir told that he wants.
Ma'am, we will take Dr. Patel sir's talk second and we will take sir's talk third. If still sir cannot join, then we will take the talk after the panel discussion. That's okay.
Okay.
So as and when sir joins, we will start. No issues.
If you want me to start also, I can finish my
Okay.
talk, ma'am.
Lalita.
If
Okay.
you want.
Hmm.
Anyways, no issues to me.
Yeah, Lalita, you can start. Then you followed by Rajamandri Lalita. Then Umashankar sir will talk. That's
Okay,
okay.
ma'am, no issues.
So I will check whether the chairpersons of second talk are ready or not.
No, ma'am, we will not change the chairpersons because then it will create an
Okay.
unnecessary confusion. Let's only
Okay.
the speaker be changed. ma'am.
Okay, okay. No problem.
Hmm.
Sir, good evening, Ramarao sir.
Good evening, Amma.
Good evening, sir.
Good evening.
Good evening, sir.
Good evening, madam.
How are you?
మిమ్మల్ని కోపాడాలి మేము మా మోసం చేస్తారు మా అసోసియేషన్ మీరు మీటింగ్ పెట్టకుండా
Mahalakshmi గారిని.
Good evening, Padma madam.
Yashodhara madam has
Good
joined.
evening. Good evening,
Yeah,
Dr. Radha. Sir, Ramara sir, good evening.
పద్మ చాలా రోజులు కనిపించావు
Good evening, sir. Madam కూడా ఉన్నారు ఇవాళ.
ఆ,
Good evening, Nirmala madam.
నమస్తే మ్యామ్. నమస్తే.
రా వచ్చే అందరూ వచ్చారు రా నేను అడుగుతున్నారు
Radha ma'am,
Yashodhara madam, I'm calling, but not
Yes,
madam, not
so
picking the
once
call.
ma'am joins and once Patel sir joins, we will start with the webinar, ma'am.
Okay, okay.
Yes, ma'am.
I'm calling the Yashodhara madam, not picking the call.
आपका कहना बिल्कुल सही है दीदी, पर इस वक्त शिव और आनंदी अपनी खुशी के
Good evening, Yashodhara madam.
Good evening, how are you?
ऐसे बच्चे के सुरक्षित भविष्य और खुशियों के बारे में सोच रहे हैं.
Monica, Yashodhara madam, Ramarao sir, Nirmala madam, all the three guests of all are ready.
वैसे भी मैंने बस सलाह दी. शिव और इस बारे में डिस्कशन.
Radha ma'am, Yashodhara madam is there.
There,
And
there.
Patel sir is also joining. I just spoke to him.
Okay.
Hi, Dr. Radha Lakshmi. कैसे हैं आप? How are you?
How are you, Monica?
Good, good, good.
Busy, Monica.
No, not busy. Bhai. You are busy. You are more busy than me. You are going for the elections?
Yeah.
Yes, ma'am.
committee?
She is going for the election.
Which committee?
Medical
Ethics.
legal.
Yeah, Ethics and
Medical legal.
Okay, good, good, good.
Good evening, Patel sir.
The tech team, can we go live now, please?
Good
Sir is
evening.
also joined.
Good evening, sir.
Radha is going to follow me because
Good evening, sir.
I headed that very committee in 2011 to 13.
Yes, sir.
So Radha is following me.
Hmm.
హలో సార్
Welcome,
సార్
welcome, sir. Welcome.
वैसे कोई खास रिक्वायरमेंट है आपकी?
The tech team, can we go live? Please start sharing.
और बच्चे किस एज का चाहते हैं आप लोग? न्यूबॉर्न.
Dr. Monica, our first speaker is joining us last.
Yeah, only the first speaker we are changing, ma'am. Chairpersons are the same.
So I will introduce in the same way, right?
Yeah, the chairpersons you will introduce. Both the Dr. Lalitas will speak first, ma'am, as first and second talk. and then Dr. Uma Shankar sir will speak.
So the first chairperson जो तीनों हैं वही रहेंगे, only
वही
the
रहेंगे, ma'am.
all right. So and I will introduce. All right, ठीक है. Okay, thank
Yes,
you,
ma'am.
thank you, thank you.
Tech team, can you please give us a countdown? We are waiting for.
Yeah, shall we start?
Yeah.
Oh, yes.
Can you stop the inauguration slide? I have to still welcome everybody, please. You will give me a countdown that we are going live. A very warm welcome to all the esteemed faculty members and the delegates who have joined in today for the 225th episode of the Masterclass Happy Learning webinar series. Today's special focus is on infertility, and we have Iluru, Guntur, Kakinada, Nellore, Rajamundry, and Srikakulam societies joining us today for this very episode. Our program director, Dr. MC Patel sir, has very carefully curated this program to select the most important talks which are very useful in our day-to-day practice. Sir is the past vice president of Foxy and a well-known medical legal consultant all across India. Sir has also headed the Ahmedabad OBGY Society, IMA Ahmedabad as National President NMO and organizing chairperson of the Vivekanand NMO. Sir, it is our pleasure to welcome you on this dais for your official welcome address after the inauguration. Can we have the lamp lighting, please? The technical team, please show us the lamp lighting. There is no audio, please. The audio is not.
The audio is not working?
No, it's not working.
Just give me a minute.
It's still not working. Anyways, thank you. I think there's a technical problem with the audio. So let us hear from Sir officially. And I would also like to welcome Dr. Radha Lakshmi Madam, Secretary of the Kurnool OBGY Society, who has helped us in coordinating this program. Welcome, ma'am.
Thank you. Good evening, all.
Over to you, sir, for your welcome address.
Thank you, Dr. Monica, for kind words. It gives me immense pleasure to welcome you all to this 225th episode of Happy Learning Masterclass web series. And today joining societies are Iluru, Guntur, Kakinada, Nellore, Rajmundry, and Srikakulam. I welcome Dr. Yasodhara Palamreddy Madam. She has kindly consented to be guest of honor to bless the webinar from her very busy schedule. Welcome, Madam. Of course, you are always with me in any of my activity, and you have always encouraged me in any of my academic activity. Thank you for the same, Madam, and welcome.
Thank you for
I also welcome Dr. V. Ramarao sir from Srikakulam. He has also kindly consented to be guest of honor to bless the webinar. And Dr. Nirmala Devi, Madam from Iluru. Both have kindly consented to be guest of honor to bless the webinar. I also welcome all the learned chairperson. Dr. Padma Sajja Madam from Rajmundry, Dr. Pandula Revti Madam from Srikakulam, and Aruna Kumari from Rajmundry. They are going to share very interesting topic to be delivered by Dr. Uma Shankar, and that is oral ovulations. I also welcome one more set of chairpersons, Dr. Y. Anuragamai Madam from Kakinada, Padmavati Madam from Bhimavaram, and Dr. Sri Sunita Madam from Guntur. They are also going to chair very interesting session, gonadotrophins in unexplained infertility. One more set of chairpersons, Dr. Venkatrao from Guntur, Dr. A.L. Satya Devi Madam from Kakinada, Dr. C. Vijaya Lakshmi from Nellore, and they are going to chair very interesting session of ovulation trigger in natural and stimulated cycle, and it is to be delivered by Lalita Madam from Rajmundri. I also welcome all the learned panelists. They are going to question in panel discussion. This is reverse panel on ART Act, Surrogacy Act, and negligence in ART practice, and I am going to answer all those questions. So I welcome all the learned panelists, Dr. Karuna Kumari Madam from Kakinada, Dr. Sama Sultana Madam from Guntur, Dr. V. Ramya Madam from Guntur, Dr. G. Ramya from Guntur, Dr. Rosni Madam from Illuru, Dr. Gunapati Mithila Sri from Nellore, Dr. T. Sri Lakshmi from Nellore, Dr. A. Sandhya from Srikakulam, and Sri Arsa from Guntur. I also welcome all the President and Secretary of Dining Society who have joined this webinar, and also welcome all the learned delegates who have joined this webinar. So this time we are going to discuss a very interesting topic related to our ART practice, and delegates who are practicing ART, they will be benefited with this discussion. When we started this series in long back in era of COVID-19, we started with 4 people, and now I am happy to announce it is more than 8,000 plus members of Happy Learning, Happy Class Master series. So without wasting much of your time and welcoming you all, thank you very much. Over to you, Monica.
Thank you, sir. We now welcome Dr. Radha Lakshmi Madam from Kurnool OBGYN Society, and we request her to please introduce our guest of honor for today. Dr. Yashodhara Madam first, ma'am.
So,
Radha ma'am, please.
Good evening, all of you. It is my proud privilege to introduce our Yashodhara Pallam Reddy Madam. Madam is a founder president of Nellore OBG Society and founder president of Nellore Menopause Society and AP State IMA Women Wing Chairperson. So, Madam, please tell your words of wisdom regarding this webinar and for the success of Dr. MC Patel sir for 2027. Thank you, Madam.
Yeah, thank you so much, Dr. Radha Lakshmi and Dr. Patel. MC, I don't know how far I will be active in mobilizing votes for you, but I really.
You have done in past also, madam. I do remember when I was contesting for VP. You
Yeah,
are
VP I
a
have
strong
done.
supporter.
VP I have done. But I'm little more swamped with other things. So still I try. I wish you all the best.
Whichever way you can.
Yeah. And of course, it's a privilege for me to join the webinar. Actually, today we were supposed to have iftar party in our hospital. So I canceled that. I postponed that program for tomorrow because of this webinar. So in the last minute, we postponed it, and I'm very much interested to join in this. And I only have a request for all the speakers and for all the audience. So try to do ART practice in an ethical way, because in public view, ART means a lot of a lot of things are happening. If not with the patients, the government has got really bad probably feedback about our ART practices. So that's why they made it very, very strict. I don't know why it became like that, but I really request all the practitioners to do in very ethical way and try to help the patient. But it doesn't mean that we lose our morals and then do. And I wish all of you the very best in your future endeavors. And just now I heard that Dr. Radhalakshmi is going to contest for the chairperson medical legal. Yeah, I wish you all the best from Andhra. Yeah, even though recently Apurva she won something, ISAR some election executive committee elections, but she belongs to Bangalore. She's Bangalore ISAR member. So from Andhra, we don't have many people. I wish that you will win this election, and yeah, Andhra should come forward. And thank you so much for giving me the opportunity. Please carry on with the other speakers and other organizers and other people. Thank you so much.
Thank you, madam, for sparing time to bless us. You are always with us in any of our academic activity. Thank you, madam.
Now our second guest of honor, Dr. Ramarao sir. He is the academic coordinator, GEMS Medical College, Srikakulam. Sir is from our Kurnool Medical College. He did his PG and UG from Kurnool Medical College from Kurnool. Worked from 1981 to 2008 in AP Medical and Health Department in various capacities. Worked in KIMS Medical College as professor at Amlapuram and NRI Medical College as HOD at Visakhapatnam. Retired from GEMS Medical College as HOD at Srikakulam. His areas of interest being cancer, cervix, NDVH, and organization issues. Sir is the founder president of the Srikakulam OBGY Society. Now, sir is the chief advisor for the Srikakulam OBG Society. Sir, you are always with us with Kurnool people. Now, I request you to be with MC Patel, sir.
Yes. I'm always with you. Don't worry. My greetings and blessings are with you.
Yes, sir. Your few words of wisdom regarding.
Yes, I think you will be very successful in your endeavor, and we will be meeting you frequently in attending these conferences. Thank you.
Thank you.
So now our another guest of honor, none other than our dear Madam Nirmala Devi Pachoti. She is the Madam is the president of Elur OBG Society, organizing, and she did APCOG 2024 in a great manner with a great success, and president of APOG 2025. She is having many awards, and Madam is a major donor to Rotary International and donated $10,000 US to US Rotary International committee. And her areas of interest is social service, music, singing, classical and light music. And Madam, your words of wisdom regarding MC Patel sir and also regarding this webinar.
Thank you very much, ma'am. Your kind words for introducing me. And I wish all the best for Dr. MC Patel sir and you also, Radhalakshmi, for your coming elections. And it's a great privilege to be a guest of honor in this webinar for me. And Dr. MC Patel is not unknown to anybody in a Foxy community, I should say. And he deserves to be the president. And we all should wholeheartedly support him. And from Andhra, Radhalakshmi Madam is created to take part in the national elections. And I wish her all the best. And Dr. MC Patel, I see him as the president already of Foxy. So I congratulate you in advance, sir. He should become the president, and he will. And all the best for the whole team of for Connect and this especially speakers. This and participants. Thanks a lot for giving me this.
Thank you, Nirmala ma'am. Patel sir?
Yes, thank you, madam,
Yes,
for
sir.
sparing time. Of course, you are always with me in all this academic activity. Thank you for the same. And before we go to academic session, I would like to welcome my team, organizing team, Dr. Monica Omerdan, convener for the series, Dr. Monica Gupta, Dr. Nivedita Datta, Dr. Deepika Logani, Dr. Satabdi Day, and Dr. Megha Kamlapur. They are coordinator for the series, and I put it on record. Special efforts by Dr. Radha Lakshmi for this particular webinar. She has helped me a lot, not only for designing, but for execution of this webinar. Thank you, Radha, for the same, and all the best for your endeavor in Foxy election as far as your committee chairperson election is concerned. Thank you, Radha.
Thank you, sir.
Thank you, sir. And thank you, Radha Lakshmi madam. With this, we declare that the inauguration for this webinar is now over. And we request all the supporting societies for this webinar to support Dr. M.C. Patel sir's candidature for presidential candidate Foxy in 2026, as well as we request your wholehearted support for Dr. Radha Lakshmi madam for the Medical Legal and Ethics Committee. Sir, with your permission, can we start with the academic session? Can I call on Dr. Deepika Logani madam to please conduct the first session?
So thank you. Dr. MC Patel, sir. Thank you, Dr. Monica, for giving me this opportunity. And I bring greetings from Delhi, and I'm a coordinator for Dr. MC Patel, sir. Good evening to all. So we now begin with our scientific session 1 for this 225th edition of Happy Learning Masterclass. And it is my privilege to introduce our esteemed chairpersons for this session. So could I have the first CV, please? Yeah, for Dr. Padma Sajja. Yeah. So our first chairperson for the session is Dr. Padma Sajja, ma'am. Ma'am is the president of Rajamundry Obs and Gynae Society. Ma'am is the consultant and director at Pragati IVF and Laparoscopic Center, Rajamundry, Andhra Pradesh. And ma'am is credited with establishing the first IVF center at Rajamundry with the first ICSI baby delivered in 2002. Ma'am is an active academician and faculty at various CMEs, contributing significantly to the advancement of reproductive medicine in the region. Welcome, ma'am. Welcome as our chairperson. Can we have the next CV, please? Our second chairperson is Dr. Pandula Revati, ma'am. Madam is the president of Srikakulam Obs and Gynae Society. Ma'am is the professor and head of department Obs and Gynae at Great Eastern Medical School and Hospital, Srikakulam, and also serves as coordinator for the medical education unit at NRI Institute of Medical Sciences, Vishakhapatnam. She has previously served as associate professor and professor at Konasima Institute of Medical Sciences, Amalapuram, and has been honored with the Appreciation Award by District Collector. Welcome, ma'am. We are honored to have you. Can we have the next CV, please? Our third chairperson for the session is Dr. Aruna Kumari, ma'am. Ma'am is the past president of Rajamundry Obs and Gynae Society. Ma'am is an alumni of Rangaraya Medical College, Kakinada, and postgraduate at PGI Chandigarh. Ma'am is a senior obstetrician and consultant at Harsha Hospital, Rajamundry. And she's also the founder president of Rajamundry Obs and Gynae Society, and having conducted multiple CMEs and conferences across Andhra Pradesh, and is invited as faculty at several state and national conferences. Welcome you, ma'am. Welcome to all our chairpersons. And can I request our chairpersons to introduce our first speaker for the session? And as already announced, Dr. S. Umar Shankar, who was the first speaker, is busy in an emergency. So can we move on to the next for Dr. Lalita?
Dr. Lalita Shirdisa, ma'am, slide, please.
Yeah. Yes.
Thank you.
Can I request our chairpersons to please introduce Dr. Lalita Sridasa, ma'am?
Thank you, Dr. Deepika, Deepika and entire Core Connect team, and Dr. MC Patel, sir, for having me here. in this prestigious series. Now, without wasting much time, I would like to introduce our first speaker, Dr. Lalita K. Shirdisa. I studied UG in Narayana Medical College from the year 1999 to 2000, and I completed PG at SV Medical College, Tirupati, 2007 to 2009, and finished DNB from Yashoda Hospitals, Hyderabad. Got presentation ICAOG in 2015-16 and participated as faculty in national and state conferences in the field of OPG from the past 17 years, and now working as director and consultant of Sairam Hospitals and IVF Center, Nellore. Now she's secretary of Nellore OB Gynae Society, and fields of interest are infertility and high risk obstetrics. Welcome, Dr. Lalita. Please deliver a lecture on
Thank you, ma'am. Thank you so much for the introduction, ma'am. So I will share my slides.
Hello.
Please keep somebody is talking and behind.
Ma'am, can you see my slides?
Yes, yes.
Yes, we can see your slides. Please make it full screen, ma'am.
ఈ మీటింగ్ త్వరగా అయిపోయింది.
Can we request
కాసేపు ఉంటారేమో అనుకుని నాకు తెలియలేదు.
Please keep it in the mute position, please.
సైడ్ ఇంట్లో ఉన్నది.
Dr.
నాకు తెలియలేదే.
Dr. Savya, please. Dr.
Yes,
Savya,
లే.
madam, please.
ఫోన్ సైలెంట్ లో ఉండిపోయింది.
Can we request all others to please mute themselves? Thank you, ma'am. Yes, ma'am. Dr. Lalita, please. We can see your slides.
Ma'am, good evening, one and all. Good evening to the senior faculties and MC Patel, sir. Thank you, sir, for giving me this opportunity. And thank you so much for the nice introduction. Today, my topic is the, actually, Uma Shankar, sir, is supposed to be a first speaker who will explain about the oral ovulogens. So now I'm going to explain about the gonadotropins and their role in the unexplained infertility. So my topic will go in 4 steps. That is the history of gonadotropins and its preparations and newer drugs, and its role in the unexplained infertility. So as we know that why the gonadotropins is important means nowadays worldwide the world is running, infertility is running behind the gonadotropins. So the widespread use of gonadotropins is there in the, especially in the ART techniques. So without the gonadotropins, no ART can be done. So that's why gonadotropin has taken a very important role in the treatment of infertility nowadays. So when we look at this slide, this is the picture we have been looking from so many years from our PG, UG and FRM and all. And this slides will explain about the how the physiology and how the gonadotropins work in the higher center. This FSH and LH and HCG, how they are useful for the ovulation, production of the egg and ovulation and the maintenance of pregnancy, and all this explained by this slide. And I'm not going to deep into this physiology of gonadotropins. As I told you earlier, when we see the census in 2019, almost 2 lakh cycles were used to be done in a year. That in the same way, by 2025, the number has been more than double. Almost 5.5 lakhs of IVF cycles has been done in 1 year. So when we see how the usage of gonadotropins per cycle is almost around 2,500 units of gonadotropins has been used on an average in a 1 cycle. So you can imagine 5.5 lakh cycles, how much gonadotropins we have to be used in a year. So for this preparation of gonadotropins, so 1 unit of HMG, we all know that these gonadotropins are mainly nowadays prepared from the urine of the menopausal woman. So 1 unit means 75 units of HMG. It requires 3 liters of urine to get 75 units of HMG. And 1 purified unit means 1 purified 75 units of FSH requires 10 liters of urine to get for its preparation. So these 2 slides I have just put into my topic because it will give a thoughtful process when we are using the gonadotropins first. So how much we should be careful before using these gonadotropins in our patients. So the different types, we all know that urinary preparation containing the human menopausal gonadotropin and purified FSH and highly purified FSH and recombinant DNA technology, and then they came the biosimilars. So when going into the historical perspectives, First is the introduction of principle of gonadotropin has been done in so in oh, I lost my slide now. I can't see my slides now.
It is visible for us. They are visible for us. Lalita?
Yes, ma'am.
You can read from that screen, no?
So I can't.
Core Connect guide Dr. Lalita. She's not able to see her.
Sure. Is it visible, ma'am, now?
Yes, sir. Visible, sir. So the introduction of, sorry for the inconvenience, introduction of this gonadotropins was done in 1926. It was the Smith who introduced this gonadotropins. He has taken the anterior pituitary tissue from the mice, cats and rabbits and induced into the immature male and female mice. Then he found out that induction of this tissue found reproduce the precocious sexual maturity and enlargement of ovaries and superovulation in these mice. So next is the discovery of the human gonadotropins, and why it has earned the name chorionic gonadotropins means it has originated from the chorionic villi of the placenta. So it has earned the name human chorionic gonadotropin. In 1927, they have found that this HCG is being collected from the urine, and we can collect the urine and blood of the pregnant woman. We can produce the HCG, and this is it has injected into the female mice, and they found that the production of the follicular maturation, utilization and hemorrhage in the ovaries of the female mice. So they have then started collecting the urine of the pregnant woman and started producing this HCG. So 1940s, more purified form of urinary HCG has been marketed. Next is the introduction of this animal gonadotropins. So in 1930s till 1960s, these gonadotropins has been taken from the pituitary glands of the pigs and sheep, and then they have found that the pregnant mare blood also having this gonadotropin HCG. So more liters and liters of blood have been taken from this pregnant mares. More number of sheep and pigs and pregnant males have been killed in the process of manufacturing this HCG. So there was in the European Parliament in the 1950s, there was an agitation and there was a revolution against this, the killing of this marathon killing of these animals for the preparation of these drugs, and the petition was raised against this manufacturing companies. So almost more than 15 lakhs people were against this killing the animals. So animal societies in the European countries came forward, and they have made a revolution of stopping this marathon. So then by the time itself, scientists have found that there was a human menopausal gonadotropin that can be extracted from the urine of the menopausal woman, which contains both FSH and LH. That time, when the petition was going on, the first nuns in the European countries came forward, and they said they are ready to donate the urine of their urine. Menopausal woman, they came forward and they are ready to donate their urine. So they requested to stop the killing of these animals, innocent animals. Then the European Parliament has made an government rule that they have to ban the preparation of this animal pituitary gonadotropins. So then so thereafter, human menopausal gonadotropin has become the preparation of choice. In 1961, first pregnancy with pergonal treatment has been achieved, and in the patient with secondary amenorrhea resulted in the birth of the first normal girl baby in Israel in 1962. Hence, the manufacturers has been attempted to produce highly purified and purified forms of this HMG thereafter. So next comes the human pituitary. Then the scientists thought, why not when it is the animal pituitary? And the animal pituitary, there were some drawbacks like some immunological reactions they have found in the humans, and also they are very short acting. So multiple doses in a day are required. So why not we go for the human pituitary? In 1958 to 1988, human pituitary preparations were successfully used for the ovulation induction. They used to take the pituitary glands from the cadavers and used to prepare the drug. But however, they have been withdrawn from the market because there were the cases of the fatal prion diseases, which is transmissible as spongiform encephalopathy and iatrogenic Creutzfeldt-Jakob disease. So they have banned using of this human pituitary also. Then, so all the pituitary tissues from the human and the animals were banned. Then they came back to the urinary products only. So next step is what we have to do. This urinary products, they are containing both LH and FH. So they have concentrated on the urinary products, more purifying the urinary products. So then they introduce application of immunocolumn with polyclonal anti-LH antibodies have been introduced. They have removed the LH from the HMG and purified form of FSH has been manufactured. These pure preparations are mainly used for the patients who have endogenous elevated LH levels. Mostly we'll see in the anovulatory cycles like PCOS. So furthermore refinement in the process taken place in late 1980s. So they have given the introduction of monoclonal antibodies. These will selectively bind to the FSH molecules, and the FSH has been prepared very purely when compared to this polyclonal antibodies, where we can see the LH activity is less than 0.1 international unit, and the urinary proteins are very, very less in that preparation. So next, what are the drawbacks in the urinary gonadotrophins? Lack of regulatory control, impossible to trace the donor source, quality cannot be checked during the transportation, urine sources cannot be validated, cross-contamination cannot be avoided, poor quality control, and the limited sources. So above all these things, there is a potential risk of transmission of viruses like HIVs and this encephalopathies with the prion diseases and the hemorrhagic viruses like Ebola virus, hepatitis C virus, and more recently the corona also can be transmitted to this preparations. So there came the recombinant human gonadotropin preparation. In 1983, production of pure FSH using a recombinant technology became possible. This involves the genome of the Chinese hamster ovary cell line. So the benefits are absence of urinary protein, more consistency in the supply, less batch-to-batch variation in the biological activity. So the world's first human recombinant preparation was polytrophin alpha that is produced in 1988 and approved in the market in 1995 as Gonalef. Second is the recombinant human gonadotropin is the polytrophin beta that is approved in 1996. So afterwards in 2000, there has been recombinant LH as Luvoris and recombinant HCG as Vovotil has been approved. And then what is the difference between this menopausal gonadotropin and this recombinant is? When we look into this, when we go into the higher preparation, the purity of FSH is becoming more and more purified. LH levels are decreasing and the urinary protein contamination is also decreasing in the preparation, so that the efficacy of the drug is becoming more and more when these contaminants are decreased. So what is the filled by mass technology? Nowadays, the drugs are prepared with filled by mass technology. Usually, the gonadotropin preparations are expressed in international units, representing its in vivo bioassay activities. In recent advances, the manufacturers has been allowed this recombinant gonadotropins has been quantified in mass in micrograms rather than their biological activity. That is called filled by mass. This reflects constant relationship between the mass and biological activity. This enables high batch-to-batch consistency. Whenever we are getting the drugs, we have to see whether it is prepared from the filled by mass technology, whether it is prepared from bioassay technology. When it is a filled by mass technology, when the drug is 75 units, then the efficacy, the 100% drug 75 units will be useful in the, the usage of complete 75 units will be there in the body. When it is the bioassay technology, there will be partial dosing of the drug will be less when compared to the field by mass technology. So when we see the overall historical perspectives, and 2010, first long-acting FSH has been approved in the European countries, and 2012, the biosimilars of all these drugs has been approved in European countries. So next is the what are the indications of these gonadotropins? We all very well know that in women, especially in the anovulatory cycles like hypo woman, where the combination of FSH and LH has been required for the stimulation, and the anovulatory PCOS women who are unresponsive to the clomiphene citrate or oral ovulogens, these gonadotropins will be used. And also in the ART techniques, as I told you, it has become part and parcel gonadotropins in the treatment of this ART techniques. In the men, treatment of deficient spermatogenesis that is caused by hypogonadotropic hypogonadism, this gonadotropin has been used. So what are the contraindications? Tumors of the ovaries, breast, uterus, testes, and pituitary hypothalamus, we can't use this gonadotropin. When there is undiagnosed vaginal bleeding, when there is hypersensitivity, primary ovarian failure, primary testicular failure, whenever there are ovarian cysts in the ovary apart from these PCOS, we should not start using the gonadotropin in those patients. So every time we have the question, which one is recombinant FSH is good or HMG is good? So which one we have to use? So there, most of the time, both are using nowadays in the control ovarian stimulation for IVF and ICSI. There are numerous RCTs and meta-analysis have been shown that commercially available gonadotropins have similar efficacy and safety profiles, but there is little difference in terms of days of stimulation, gonadotropin dose, number of oocytes we have retrieved, and final estradiol and progesterone levels, cancellation rate, and pregnancy and live birth rate per a woman. But a Cochrane review in 2003 showed that there is no difference in the ongoing pregnancy and live birth rate per woman in IVF ICSI cycles using both recombinant and HMs. In 2005, meta-analysis have showed no significant difference between the HMG and recombinant FSH in terms of ongoing pregnancy, live birth rate, clinical pregnancy, miscarriages, multiple pregnancy, and OHSs. So what are the safety of this drug is, how safe these gonadotropins are. The effects of gonadotropins on pregnancy, fetal development, delivery, and its effects on fetus, infants, they do not differ from the outcomes reported in the general population. But only thing we have to keep in mind is the individualization of ovarian stimulation protocol, essential for this when we are using the gonadotropin in order to avoid the complications like multifetal gestations and ovarian hyperstimulation syndrome. So finally, what are the factors that we have to be considered before deciding the dose of the gonadotropin is, mainly we have to see the age of the woman, BMI, basal FSH, estradiol, AFC, and AMH. These are the main factors we have to take into consideration before deciding the gonadotropin dose in every woman, because individualization of gonadotropin, it is not standard to everyone. This individualization will prevent the complications of using this gonadotropin. So when we see this Biasoni criteria for starting the dose of this gonadotropin, this criteria mainly takes into consideration age of the patient, BMI, basal FSH, and AFC. So this criteria omitted the patient more than 40 years, BMI more than 30, less than 19, and basal FSH if it is more than 10 and AFC less than 8 have been excluded in this criteria. So a word on the luteal phase support. So whenever we are using the gonadotropins, even for a simple ovulation induction or for IUIs, we have to support the luteal phase with the progesterone, because this gonadotropins will suppress the endogenous LH levels and cause the luteal phase insufficiency. So whenever we are using these injections, gonadotropins, we have to support the luteal phase with the progesterones. So what are the newer preparations? Folitropin beta, polytrophin delta. It has been prepared from the fetal retinal cells of the human, and it has different glycosylation product pattern from both polytrophin alpha and beta. So it cannot be dosed according to the bioactivity. As I told you, it is dosed instead of by its mass. In the phase 3 study, they compared the individualized doses of polytrophin delta on 1,326 women. So they have demonstrated non-inferiority of the delta to polytrophin alpha. Ongoing pregnancy rate was almost similar. Ongoing implantation rate is also similar. Live birth rate is also similar in both these groups. So there are only fewer members out of 1,300. Only 75 women required the preventive measures for OHSS. Next comes the polytropin epsilon. It has been derived from the myeloid leukemia cell lines of the human, but it is not in the currently it is not in the market. Next is the polytrophin alpha. It is due to the short half-life of FSH. We have to take the FSH daily, and which is inconvenient to the patient, unacceptable burden to the patient. So long-acting recombinant FSH has been prepared. The only approved long-acting was developed by addition of carbonyl terminal peptide of the beta subunit of HCG to the beta subunit of FSH. It is marketed as Elnova. And the risk and risk benefit balanced is very positive in the polytrophin alpha, with few adverse effects reactions like OHSS, headache, pelvic pain, fatigue, and breast tenderness. Polytrophin alpha has been admitted as a single subcutaneous injection, which replaces the 7 daily doses of FSH therapy. It has 2-fold longer half-life, almost 4-fold longer time to peak the serum levels than other available FSH preparations. So meta-analysis of RCT showing that daily injection of recombinant FSH in women receiving ART treatment found no significant difference in live birth rate, ongoing pregnancy rate, and the pregnancy rate, clinical pregnancy rate, and no differences in the OHSS also. So next, why can't always we are taking the injectables? Why can't be the oral gonadotropins? So when we see the research, it is not possible to dose the gonadotropin orally because they are the proteins. They will not be absorbed. Rather, they are digested very easily by the enzyme. So oral gonadotropin preparation cannot be prepared. So when we see this slide, as the time progresses, the safety, quality, consistency, and the patient convenience has been made increased, and the purity and specific activity of the drug in the drug also been increased when the time moves from 1931 to 2013. So next comes the last part of my talk is the unexplained infertility. So GDG defines the unexplained infertility as a couple with apparently normal ovarian function, fallopian tubes, uterus, cervix, pelvis, age less than 40 years and with adequate coital frequency, and apparently normal testicular function, genitourinary anatomy, and the normal ejaculate. So they will come under unexplained infertility. When we jump into this management of unexplained infertility has been based on the age. And the age is less than 35, between 35 to 39, and more than 40 years. Less than 35, the duration of infertility is when it is less than 2 years, then we can do the expected management for 2 years. If it fails, then we have to go for the gonadotropin stimulated IUI cycles. If it is more than 2 years, we are directly moving on to the ovulation induction with gonadotropins and IUIs. If it fails, then IVF. If the age is between 35 and 39 years, so we have to wait. The duration of infertility is more than 1 year. Then we are directly going into the HMG stimulated IUI cycles. If it fails, then we go to the IVF. If it is more than 40 years, irrespective of duration of marital life, we directly jump into the gonadotropin stimulated IUIs only for 2 cycles. If at all it fails, then IVF. Otherwise, we can directly go into IVF also. So There are some studies which shows that gonadotropins play important key role in the unexplained infertility. Number one is the classic study that is done on 1999. This includes 932 infertile women of more than 1 year of marital life with 32 years of age. They have shown that intracervical insemination, the pregnancy rates with intracervical insemination and with IUI and gonadotropin with IUI, it is and with intracervical insemination. They have been shown that the maximum percentage of pregnancy has been found in gonadotropin stimulated cycles and IUI. So, 4 cumulative pregnancy rates of 4 cycles in the gonadotropin stimulated IUIs are almost 33% when compared to the other arms. So the key message in this study is controlled ovarian stimulation with the gonadotropin combined with the IUI significantly improves the pregnancy rates compared with insemination alone in the couples with unexplained infertility. Next is the FAST trial that is conducted in 2006, and this study involved 503 couples with unexplained infertility. So the comparison of this treatment strategies is the conventional arm showing clomiphene plus IUI. Then if fails, then jump into the gonadotropins plus IUI. If it fails, then IVF. Accelerated arm shows trying the people with clomiphene and then IUI. If it fails, directly jumping into the IVF. The result showed that accelerated treatment resulted in shorter time of pregnancy, higher cumulative pregnancy rate, and lower overall cost is lower when we compare with conventional arm. So conclusion is keeping of gonadotropins plus IUI and proceeding earlier to IVF may be more efficient in some patients, especially if the age of the patient is more than 40 years. Then fourth trial. This study included mainly the age group of women between 38 to 42 years. So the treatment arms of clomiphene plus IUI, gonadotropin plus IUI, immediate IVF. Results showed that IVF demonstrated the highest pregnancy and live birth rate with shortest time of pregnancy. So in older women with unexplained infertility, early IVF may be preferable to multiple IUI cycles. So Amigos trial, this is the large randomized trial including 900 couples with unexplained infertility. So the arms are gonadotropins plus IUI, clomiphene plus IUI, letrozole plus IUI. When we see the pregnancy rate, it is almost 32% and it is maximum in gonadotropins stimulated IUI cycles. So conclusion is gonadotropins have higher pregnancy rates but are associated with significantly increased multiple gestation. So what is the current clinical approach by seeing all this trial is that in unexplained infertility, expectant management can be done in the younger couples with shorter duration of fertility. Ovulation induction with letrozole and clomiphene should be combined with IUI. Simple ovulation induction, it doesn't work in unexplained. And gonadotropin stimulated IUI in selected cases will be with careful monitoring will produce the maximum pregnancy rates. If IVF, if previous treatment fails, if it is the older woman, then directly go for the IVF. So my key take home messages about this gonadotropins are, these are effective for ovulation induction, important role in specific infertility groups, better outcomes with proper patient selection, but monitoring is very much essential when we are giving the gonadotropins to the patients. Risk of complication must be explained, and cost and the patient burden should be considered before starting this gonadotropins. Individualized stimulation protocols will definitely improve the safety and success of the treatment. Thank you so much. I thank everyone for patient listening. I thank Radha Lakshmi ma'am and I thank MC Patel sir, especially giving this opportunity to participate in this webinar.
Madam, Revati madam, you were concluding remarks, madam, for the first session. Revati madam. Madam, you are muted. Revati madam. Madam, you are muted.
Revati madam, you are muted, ma'am. Please unmute yourself.
Revati madam, you are muted. Ramarao sir.
Sir, sir, you are also muted. Please unmute yourself. Yes, sir. Thank you.
Yes.
Revati madam, you are muted, madam.
Ramarao sir, you've muted yourself again.
Ma'am, there is a mic-like button on the extreme right of your laptop. So you can have to just press it once. Yes, Ramarao sir, please.
Constantly getting.
Core Connect team, can you unmute them?
No. They can unmute themselves.
They
I
can
can
mute
ask them
them.
to mute, but they can't be
Can't
mute.
unmute.
I will call madam.
Ramarao sir and Revati madam, on your laptop, if you join from your laptop, on your left hand side below, there's a mic button which says audio. Just press it once, you will get unmuted.
Hello.
Yes, sir.
Yes, sir.
Ramarao sir,
Yes, sir.
you are unmuted now.
Yeah.
Hello.
Please. Yes,
Yes,
sir.
sir. Sir, please give your
Am I
comment.
audible to you?
Yes, sir. Very audible.
Madam, మీరు mute అన్నారు.
Particularly, unmute a historical aspect, because most of the things we cannot get. Historical aspects he has how the genesis of this prostaglandins he has nicely narrated. Very good lecture. Thank you.
Thank you, sir.
Congratulate
Thank you,
Lalita.
sir. Thank you, sir.
Thank you, Lalita, for your excellent presentation on evolution of Gunda topics. Really interesting.
Thank you, ma'am.
Whatever said and done, we have to always take the opinion of the couple. Many are getting married late and they want to go in a second manner for so many years in spite of
Sadia, please unmute yourself. Sadia, madam, please unmute yourself.
recently have
Tech
delivered
support, please mute Dr. Shravya.
who has conceived naturally and delivered uneventfully. So we can always, we should always take the woman's opinion, couple's opinion into consideration before we go for higher treatments and all.
Yes, ma'am. Yes, ma'am. Definitely.
Yeah. Nature will suddenly give us surprises. Thank you so much. Thank you, Patel sir, for your upcoming, for giving me this opportunity, and all the best for your upcoming presidential elections. Thank you, Radha madam, for your upcoming elections as chairperson to Medical Legal Committee, and our best wishes from Rajahmundry OB-GYN Society to your elections, and we will be always with you, Patel sir and Radha.
Thank you, madam.
Thank you, respected. Yes, thank you, respected chairpersons. Thank you, respected chairpersons, and Dr. Lalita for the wonderful talk on the gonadotropins. Moving on to the next session,
Thank you.
We have the next session. The speaker is again another Dr. Lalita, and to chair this session, we have three very eminent gynecologists: Dr. Anuragamai, Dr. G. Padmavati, and Dr. C. Sunita. So yeah, could we have Dr. Anuragamai? Yeah, please go back. She is the president of Kakinada Obs and Gynae Society and is the professor and HOD of Rangaraya Medical College, Kakinada, at the present moment. The next chairperson for this series is Dr. G. Padmavati. Madam, she is at present the president of Bhimavaram Obs and Gynae Society. IMA president. She's a senior resident from Fernandez Hospital, which is famous for its stillbirth protocols as well as managing high-risk pregnancies. So, senior resident from Anu's Infertility Center, Hyderabad, civil assistant surgeon at ESI Hospital, Sanat Nagar. She has interest in free medical camps, female education, free cancer screening camps, and has conducted more than 150 such camps in her mother's name for the past 15 years. Her mother must be really proud of such a noble daughter. She has received multiple awards, especially the Zaveri Award for the best paper presentation at AIGOG 97 Hyderabad. The next chairperson for this series is Dr. C. Sunita. She is the professor at Rangaraya Medical College, Kakinada. She's an associate professor at Guntur Medical College, Guntur, and has worked as an assistant professor at Kurnool Medical College, Kurnool, with such a great background in the medical colleges. She's also been a TU trainer of trainers for PPIUCD and Lakshya, and a field of interest in high-risk pregnancies and preventive oncology. I would request any of the chairpersons to please introduce the speaker for today. And this is Dr. Lalita, who is going to speak on his trigger in natural and IUI cycles.
I think only Sunita madam is there. I request Sunita to introduce Lalita, Kambam Party of Rajamandri. Sunita? Sunita, are you there? Sunita?
Yes, madam.
Yeah, please introduce. Yeah, please start. Yeah. Sunita?
Madam, am I visible?
Yeah. You can start. Please go ahead, Sunita.
Good evening, everybody. Today, I have the privilege of introducing Dr. Lalita Kambampati. She is consultant and director of Lalita IVF at Helios Hospital, Rajahmundry, present secretary at Rajahmundry Obstetrics and Gynecological Society. She completed MS OBG at Seth GS Medical College and KEM Hospital, Mumbai. She is senior registrar at Bark Hospital, Mumbai. Fellowship in reproductive medicine and infertility from Netgay Hospital, Hyderabad. She did fellowship in histoscopy and laparoscopy from Nandkarni Medical Foundation, Gujarat. Her special interests are in sexual medicine and menopausal health. She presented papers at national conference and published in national and international journals. Now I request Dr. Lalita Kambampati to give her elaborative lecture. Thank you.
Thank you, ma'am, for that wonderful introduction. Can you see my screen? Hello?
Yes, Lalita, we can see.
So after that wonderfully informative session, my session on ovulation triggers is going to be really short and sweet. So here it goes. We will be talking about triggers. So first we'll just have a quick look through the physiology of ovulation. We all know like there is a release of FSH and LH, and after FSH the follicle grows, and there is a release of estrogen, and once there is a sustained peak of estrogen, initially there is a negative feedback of estrogen on the FSH and LH, so that monofollicular growth is to be seen. But at a certain level of estrogen levels, and once the peak of estrogen level is maintained for at least 12 hours, there is a LH surge. And along with it, there is a pre-ovulatory rise of 17-hydroxyprogesterone, which facilitates the positive feedback and induces a smaller surge of FSH. And once we have both of them happening, in the next 36 hours, there is increase in plasminogen activator, release of plasmin, which facilitates the lysis of follicular wall, and the LH surge causes resumption of meiosis and leads to extrusion of ooze after follicular rupture. So initially, like ma'am said, we only had HCG trigger, and they were using in the GnRH agonist pre-treatment cycles, long protocols in IVF also, and for natural cycles and everything, only HCG was used. It was the most commonly used trigger, and I think it is safe to say even now it is still the most commonly used and most well-known trigger. Now, HCG has a higher affinity for LH more than and it has a long lasting for 5 to 8 days. Because of its effect, and we all know with a normal LH surge, there is also an increase in VEGF receptors, which will actually improve our pregnancy rates. But because HCG is much stronger with higher affinity and It is the longer acting drug. There is a
1 minute,
extreme
Lalita.
release
I
of-
request the Sohail to mute everyone. Please mute everyone other than Lalita. Okay, you continue, Lalita.
Right. So, because of its long-acting effect and because of its higher affinity, and there is an increase of VEGF and other peptides like that, there is an increased risk of OHSs, especially in PCOD cycle, PCOD, or when there are multiple follicles recruited. Hence, when we have more than 2 to 3 follicles, even if they are not of 17 or 18 mm, even if we have multiple follicles, it is not recommended to use the HCG trigger, especially in patients with PCOD. Now, the most common question a lot of people ask is there are a huge amount of number of injections which are available in the market. There is a especially the dosages range anywhere from 1500 to 10,000 of urinary HCG and a recombinant HCG of equivalent to 6,500 international units. Now, is there any difference in their usages? So we have had many studies showing that whether we have used 7,500, 10,000 international units or 5,000, the efficacy, the pregnancy rate, or even the rate of severe OHSs is the same. So might as well use the lowest possible HCG dose for a trigger. Now the question comes, is there a better use of recombinant HCG? See, now recombinant HCG is not urinary, has lesser impurities. So the local site of injection, local reactions may be lesser. But if you see, there are similar clinical outcomes in timed intercourse IUI or IVF. In this study especially, they have shown few non-randomized studies, especially in IVF cycles, which showed recombinant HCG to provide a higher rate of M2 metaphase 2 oocytes, and significantly, but it was not statistically significant. Hence, the actual clinical outcome, pregnancy outcome, has not increased with the use of recombinant HCG. But definitely, local injection adverse effects were local site adverse effects were lesser. Then we started developing GnRH antagonist to prevent the premature LH surge in IVF cycles. With that, we had decreased the risk of OHSs that was being seen with the previous GnRH agonist cycles. Now, they started thinking, because HCG trigger has a very high affinity for LH and a prolonged duration of action, why can't we give GnRH agonist as trigger? Now, what does it do? GnRH agonist, as we all know, will cause a flare effect, and there is an immediate release of FSH and LH. Now, we all know an HCG trigger will only simulate a LH surge. But physiologically, when we see, there is a small surge of FSH. Now, GnRH agonist will show us an increased LH surge and a small FSH surge. So, it is more physiological. And because of its shorter action, and it has a negative effect on VEGF receptors, it does not cause OHSs. In many studies comparing the use of HCG and GnRH agonist as trigger in GnRH antagonist cycle in IVF, they have almost shown 0% increase in severe OHSs, which was a huge relief for IVF practitioners everywhere. But there are some conditions where we cannot use GnRH agonist, which is when we are using a long protocol, because clearly we have suppressed it to a level where another shot of GnRH agonist is not going to give you the flare effect. And it is also not suitable for patients with hypothalamic dysfunction, anorexia nervosa, or hypothalamic amenorrhea, hypo conditions, hypogonadotrophic hypogonadism. So in such cases, we can only use HCG as trigger. Now, we have many GnRH antagonists. Commonly, we have used triptyline and leuprolide. There is intranasal butyrin also, but the most commonly used agonist triggers are triptyline and leuprolide. The dosages are most commonly triptorelin 0.2 mg or leuprolide 0.5 to 1 mg. Now, please to be noted, leuprolide 0.5 mg can be given in 2 doses over 12 hours apart, and same with triptorelin 0.1 mg can be given in 2 separate doses 12 hours apart. Now, if for any reason, whether it is an ovulation induction cycle or IUI, we have used GnRH antagonist to prevent any premature rupture of the follicle. It is to be noted that it is not, sorry, it's not 6 to 7 hours, not 67. A gap of 6 to 7 hours is preferable before administering the agonist trigger. Now, sometimes there are people who suspect the agonist trigger might have failed. Now, how do we know whether it has failed or not? If after 12 hours also, after giving an agonist trigger, once we see LH and progesterone levels, if they are not rising, if you don't see the LH surge, then if in that cycle it is possible and is safe to give a HCG trigger, we can repeat the HCG trigger. The most important point to be noted in GnRH agonist cycles is that initially, when they had introduced GnRH agonist as a trigger, the pregnancy rate fell sharply in all cycles, including IVF. Now, the reason for that is that GnRH agonist has only a flare, and after that, it will suppress all the endogenous hormones. So, the luteolysis occurs very quickly after GnRH agonist. So, it is very important that we give aggressive luteal support so that pregnancy rates are equal and clinical outcomes are unchanged with a GnRH agonist, and we can safely use them to prevent OHSS. Now, after GnRH agonist, now we started thinking, why can't we mix both of them? We have some benefits with HCG and we have some benefits with GnRH agonist. Why not we combine both of them? If it is possible to give HCG in a full dose, adding half dose of GnRH agonist will improve the FSH surge and improves the ovulation or ovarian maturation, and in IVF cycles it improved the yield of N2 oocytes and hence increased the pregnancy rate significantly. When we are using, if we are suspecting a small that it may cause OHSS, we can decrease the HCG levels up to 1500 to 2000 international units and give the full dose of GnRH agonist so that we can give them the benefit of a prolonged luteal support as well as FSH and LH surge and a good oocyte maturation. So this is a study published in 2022 by Halim et al. Where 639 IUI cycles were studied, of which there was a randomization done between dual trigger and a single trigger with HCG. The clinical pregnancy rates were significantly higher in the dual trigger group than the single trigger group. More than 2.5 times pregnancy rate improved in IUI cycle. So it is a point to be noted that dual trigger is a beneficial option if we can add HCG also. Now, this is not exactly into my topic, but I thought it is prudent to talk about the efficacy of using ultrasound and improved use of ultrasound to properly monitor the cycles so that we can give the right trigger at the right time so as to increase our pregnancy outcomes. So this is mostly taken from articles, especially by the extraordinary work done by our own Sonal Panchal madam and Chaitanya Nagori sir. So these the optimum way to monitor an ovulation induction cycle is by using power Doppler. See, as you can see in the follicle, that in this picture there is more than 3/4 of the follicle covered by flow, showing that the adequate oocyte maturity. Now, if we can see the power Doppler there and see the Doppler levels and the blood flow, if the perifollicular resistance index it is less, that is 0.4 to 0.48, and the PSV more than 10 centimeter per second, that has shown an increase in pregnancy rate up to 30 to 40% in just your ovulation induction or IUI cycles. point to be noted is that the settings of ultrasound have to be very carefully checked. The setting of PRF should be at 0.3 and wall filter should be at the lowest. So usually we measure a size from inner to inner diameter and we will see a mean of 3 orthogonal diameters. So I will in the further slides I will be talking about the diameter, but first I wanted to show you that like by using power Doppler and Doppler indices of the perifollicular blood flow, we can improve pregnancy levels even in our IUI cycles. This is a article which was published by Sonal Panchal madam and Chaitanya Nagori sir, where they have showed that the conceptional rates were significantly improved with a higher peak systolic velocity and a lower perifollicular resistance index. Why is it so important? Is because once we see these values, we can optimize the timing of giving the trigger. Now, optimal follicular size for HCG trigger, the most important thing to be noted is it differs by the by the ovulation induction agent which was used in the cycle. If we are using a letrozole induced cycle, especially which is especially common, the most pregnancy rate was seen, which is 18% at 22 mm. Now, less than 19 mm or 19 mm, it fell to 12.9%. And once the follicle increased in size, it fell again to 11.43%. So it is very important to carefully monitor and time the trigger to give the maximum results to the patients. Now, when we are talking about letrozole with HMG or any gonadotropin use, there is a small chance of spontaneous LH surge. So when we don't have a spontaneous LH surge, the pregnancy rate was around 20% with just 16 to 18 millimeter. And in the spontaneous LH surge group, even 14 to 16 mm showed that the pregnancy rate was significantly higher. And it is very important to note that 2 or more lead follicles improve the pregnancy rate by 2.5% time. With our latest AI in all our ultrasound machines, we have AI tools such as Sono AVC and other tools which will allow us to measure volume. Now, a follicular volume of 0.56 centimeter cube at trigger has shown a good cutoff to predict oocyte maturity in all cycles, including IVF and IUI. Now, it is very important also to note that the interval between trigger and IUI should not be less than 36 hours and it should not be more than 42 hours. This is a study published by Indian authors where they have shown the maximum pregnancy rate up to 25% seen with 36 to 38 hours after trigger. Now, we have done everything possible and we have checked the ultrasound after 36 hours after trigger, 40 hours after trigger, 48 hours after trigger. Now, the follicle is unruptured. That is, there is no decrease in the size or the morphology of the follicle. But progesterone levels have started raising. That is called luteinized unruptured follicles, and it is not as rare as we think. More than 25 to 50% of cycles of ovulation induction and IUI can show luteinized unruptured follicles. Now, the reason can be multivariable. It can occur especially in unexplained infertility, especially when there is endometriosis or pelvic infections, if there is use of concomitant use of NSAIDs, which will prevent the follicle to actually rupture. So now, what do we do? There are 3 to 4 things that we can do. The first thing is to check if we can increase the trigger or add a dual trigger. The second thing is to optimize the timing of trigger. Like I told you, there are 3 to 4 tools that we can use and to optimize the exact time that we should give the trigger. Now, also the ovulation induction agents like letrozole or HMG, those cycles have a lesser incidence of LUF than clomiphene citrate. Also, another point to be noted is if you're using clomiphene citrate cycles, then the optimum size to give trigger is around 22 to 24 mm. Now, in any other cycle, more than 24 mm shows decreased pregnancy rate, but if clomiphene is being used, then definitely 22 to 24 mm has shown good pregnancy outcome. And luteinized unruptured follicles is a situation which can occur in subsequent cycles. Now, it is occurring in the next 3 to 4 cycles also. It is better to counsel the patient for IVF. Finally, there are some studies which have shown the use of GCSF, which is granulocyte colony stimulating factor, given to 12 to 24 hours prior to HCG, which will improve the rates of ovulation. This is something we can try before going on to IVF. And with that, I would like to conclude my presentation. Thank you so much for your patient hearing, and I would like to open the floor for any questions.
Thank you, ma'am, for your excellent presentation. I request chairpersons to please give concluding remarks. Chairpersons, please. Or Radha Lakshmi, ma'am, you can give some concluding remarks on this.
Yeah. So, Lalita, very nice lecture regarding ovulation and also regarding the size of the follicle, when to give the HCG and GnRH analogs, and your closing remarks regarding GCF. So, thank you for your great lecture.
Thank you, ma'am. Thank you,
Mm.
ma'am, Dr. Radha Lakshmi, for giving me this opportunity. And thank you, Dr. MC Patel, sir, and Core 9 Connect team, and everybody, all the seniors present, for giving us the encouragement and giving us the floor to participate. And I wish you all the best, Dr. MC Patel, sir, and Radha Lakshmi, ma'am, for
Thank you.
your future elections. Thank you so much.
Thank you, Lalita.
Thank you, Dr. Lalita. I think that was very clear-cut message to the audience about when to give the trigger and when not to give the trigger. Thank you, Dr. Lalita, and thank you, chairpersons. Thank you, Dr. Radha, for coordinating so well throughout the session. I now hand over to the next coordinator for conducting session 3, which is actually session 1.
Yeah. Dr. Monica.
Thank you. Thank you very much for giving MC Patel, sir, for giving me opportunity to speak in this prestigious webinar. And it is my proud privilege to introduce this so many eminent faculty from the South, Dr. Padma Saja Madam, Dr. Pandula Revati Madam, and Aruna Kumari Madam. And the talk is on oral ovulations by Dr. S. Uma Shankar, sir. Please put the CV of the chairpersons, please.
So it will be third
Next.
session chairperson, so Dr. Venkat sir.
The chairperson will be the same. Dr. B. Venkateshwara Rao, sir. Please put the CV. CV of the third.
CV of Venkat sir. Venkateshwara sir.
Please put the
Chairperson.
CV.
Third session.
Third session. Satyavati Madam, Vijaya Lakshmi Ma'am, please stop sharing the presentation. Core Connect team. Please put the CVs of the chairpersons of the third session.
Yes.
Dr. Venkateshwara sir, Rao sir, he is a MD, DGO, FICOG, professor and HOD of Kathuri Medical College and Hospital, Guntur. He is a president of the society from the Guntur, and he is a very senior gynecologist and working very hard with so many accolades into his credit. Next. Please change. Dr. Satyavati ma'am, she's a founder and director of Sruja Multispecialty Hospital and IVF Center and Sruja Cosmetic Gynecology Center at Kakirara. She's working for so long in the Kakirara and she's a famous personality over there. Next. Dr. Vijay Lakshmi ma'am, she's a fellow in IVF, laparoscopy and hysteroscopy, a specialist in ART and minimal invasive surgeries, and she has got n number of presentations in the field of infertility, and she has received the awards like MS Signature International Award from Nitin Gadkari at Himachal Pradesh in 2021, received Best IVF Specialist from Indian Ambassador at Kuala Lumpur, Malaysia, and received Excellence in Empowerment Award from Dr. Kiran Bedi, IPS at New Delhi in 2024. I request any of the chairperson to introduce Uma sir.
Madam, sir.
Satyavati ma'am, please, can you introduce?
Yeah. Good evening, one and all. And I would like to congratulate and best wishes from Kakinada Society to MC Patel sir and Radha Lakshmi madam. And it's my privilege to introduce Dr. Uma Shankar. He is a clinical head at Ahalya IVF Group, Andhra Pradesh, Guntur. And he won Jagadishwari Mishra National Award 2 times and won Indian Greatest Leader Award in the year 2016 to 2017. And he's inspired many gynecologists and IVF of India Award 2019 and Foxy Dira Award 2022. And over to you, sir, for your lecture. Uma Shankar, sir.
Thank you, madam, for your kind introduction. I'll just start sharing my slides. So, meanwhile, I thank MC Patel, sir, and for Radha Lakshmi, madam, and all the coordinators for giving this wonderful opportunity to be in this webinar, Happy Learning webinar. Yeah, today the topic is an overvigilance. I think it is the bread and butter of all IVF specialists or infertility specialists and gynecologists as well. Because anyone who is infertile would like to take some treatment for from all gynecologists, and oral ovulation is the first line of treatment for them. So we divide infertility women into hypogonadotropic hypogonadism, normogonadotropic normoestrogenic, hypergonadotropic hypogonadism. So in the first group, we have decreased GnRH, decreased FSH, LH, decreased estrogen. And the causes are hypothalamic dysfunction, stress, excessive weight loss, and other syndromes like Kalaman syndrome. So the second group is normogonadotropic normoestrogenic. This is the most common group which we see. And the main problem is the ovulatory dysfunction, and this is the most common group. It includes PCOS and other anovulatory dysfunctions. And the third group is hypergonadotropic hypogonadism, which we are seeing more nowadays, especially after the post-COVID. We are seeing there is high FSH, LH, they are towards ovarian failure, they have decreased estrogen, causes premature ovarian failure, gonadal discharges, and I think post-COVID, many of the ovaries, they are going now into group 3. So what are oral ovulations? They are drugs used to induce ovulation. Their first line of therapy in ovulatory infertility, common in PCOS and irregular cycles. The advantages are simple, affordable, and outpatient treatment therapy is easy in these patients. So how do we classify them? They are the old drugs, that is clomiphene citrate and tamoxifen. The new aromatase are letrozole. And we have adjuvants, that is metformin and dopamine agonists. Especially when we see higher prolactin levels, dopamine agonists play an important role in ovulation induction. So how do they act? So clomiphene citrate, it blocks the estrogen. So it blocks the estrogen receptors and there is no estrogen. The brain thinks there is hypoestrogenic, and due to a negative positive feedback effect, it releases the FSH hormone and it causes ovulation. And what happens when you see what the letrozole? The letrozole, what happens with letrozole? Letrozole prevents formation, that is aromatase inhibitor. It prevents the
Can I
formation.
request everybody else to please mute yourself so that sir can speak? The host, can you please mute everybody?
Yeah.
Yeah.
So
please continue. Thanks.
yeah,
Sorry.
yeah, no problem. So letrozole, what happens is it stops aromatase it inhibits aromatase, and there's no estrogen production. Then they think there's hypoestrogenic state has occurred, and then the brain releases FSH, and there is ovulation occurs. So what are the things? The first generation is clomiphene. It is anti-estrogenic. Tamoxifen, less anti-estrogenic. Clomiphene has a very anti-estrogenic effect on the endometrium. Tamoxifen has less anti-estrogenic on the endometrium. Letrozole, it is more or less a physiological ovulation where there is FSH rise occurs because there is and there is no effect on the endometrium, especially when people are having thin endometrium. Letrozole works wonders in that. So the mechanism of action of, so what happens? CC blocks estrogen receptors in hypothalamus, negative feedback, increase GnRH, increase FSHLH. So it induces ovulation. The same thing, what happens is it blocks receptors not only on the endometrium, it blocks receptors on the GnRH hypothalamus, it blocks on the endometrium one and cervix. So it has the other side effects. There is thin endometrium, poor cervical mucus, because estrogen receptors on endometrium and cervical mucus are occupied by clomiphene citrate. So whereas letrozole is an aromatase inhibitors, decrease estrogen synthesis, decrease FSH release, and increase follicular sensitivity to FSH. There is no anti-estrogenic effects on the endometrium. So how it acts? Estrogen. By the way, all the drugs, estrogen is decreased, negative feedback, GnRH agonist is increased, FSH is increased, and increased follicular recruitment occurs in this. What are the dosages that we have? We start with a minimum dose of 50 milligrams, and we have to give it for 5 days. And there's another, these are the standard protocols. We can give it any day. Most of the studies say any day is okay. There's day 2 or day 5. We can start any of these days. They do well. And the maximum dose is 150. Previously up to 250 were given, but now maximum dose is 150. And we can try a maximum of 6 cycles at a time. So letrozole is 2.5 milligrams per day. It is given for 5 days. It is 3 to 7 day starter. You can give anything. There's another dose is 7.5 milligrams per day also can be given to the maximum dose. There are some regimes where we can give up to 10 days also. And these are, letrozole is much better than clomiphene citrate in ovulation induction and causes unifollicular development compared to CC, which has multifollicular development. So tamoxifen dose is 20 to 40 milligrams per day into 5 days. It is alternative to clomiphene, especially in clomiphene failures. So the protocol starts on day 2 to day 3. Start the drug, you do a scan on day 10, and you do it daily until the follicle reaches 18, you give ovulation trigger. As previously said by one of our Dr. Lalita, that you have to be careful. If you're using clomiphene citrate, you can wait up to 24 mm because that is when the real maturity occurs. Because when you're giving clomiphene citrate, a lot of fluid comes into the follicle compared to letrozole. So that's why the follicle size is much bigger when you're using clomiphene citrate for trigger. So letrozole protocols, day 2, you do a baseline scan. You start letrozole from day 2 or day 5, day 3 up to day 7. And you have to do a follicular monitoring 10 to 12 days. I'm just sorry for the phone call. Yeah. So it's when it reaches 18 mm. So from 18 to 20, usually in my practice, because the book says 18, but in my practice, I give up to 20 or 21 also when we use letrozole. And more than that, I follow what Sonal Panchal Madam has said. We follow the blood flow of the ovary as well as the endometrium to give a trigger. And then we give advisor time intercourse on IUI. So again, it's the same thing with the clomiphene citrate. And we have a combination protocol, especially in PCOS, where we actually letrozole and metformin is given. But in now my protocol, what I do is we give metformin 3 months prior with down regulation with diane 35, that is diane 35, 3 months metformin, and then we put them on letrozole metformin. We have very good results. And we have clomiphene plus HCG trigger, letrozole plus IUI, we can give any of these things. The trigger is already discussed by our previous things, so I'm not going into things. So what are the advantages are? They are oral things. It can be taken oral, no need for any injections. They're very cheap, easy, and OPD treatment can be done. So the disadvantages is clomiphene citrate especially has multiple pregnancy, anti-estrogenic, and failure in some of the patients. So when to switch? There's no ovulation after maximum dose. So once you reach 150 in cc or up to 7.5 in letrozole, when there's no ovulation, you switch. When the endometrium is very thin and if the endometrium less than 5 mm, there is very difficult for pregnancy to occur. So in those cases, and no pregnancy after 3 to 6 cycles, it's better to switch over. Summary: oral ovulagens, cornerstone of infertility treatment. The evolution has occurred from clomiphene to letrozole. Letrozole is now preferred drug, but in PCOS and in some of the patients, we can actually go in for clomiphene citrate. Individualized protocol improves success. Thank you.
Thank you, sir. Your talk was crisp, to the point, and clear what to do and what not to do, what the real doctors and practitioners and the periphery workers, they really need it. I request chairpersons to give their comments.
It was a wonderful lecture, Dr. Umashankar.
Thank
And
you.
oral ovulagens actually easy to use and quite affordable to almost all the patients. And the first line of therapy, even I prefer oral ovulagens. And very nicely narrated the mechanism of action and the combinations. It was wonderful. Thank you very much.
Thank you, madam. Thank you.
Thank you, Umashankar sir and Satyavati madam. You are the great pillars of infertility treatment in Andhra Pradesh, madam. Sir is the first I think the leading infertility specialist, and sir is the president of ISAR Andhra Pradesh.
Yes, thank you, madam.
And I request Padmavati madam, the chairperson for second session. So if you are there, please, your remarks. Padmavati madam. Madam is not there. Okay. Monica, you carry on.
Thank you, sir. Thank you. Over to the next coordinator for the fourth session. That is much awaited panel discussion on negligence in ART practice and ART Act. Dr. Shatabdi?
Yes, ma'am. Good evening, ma'am. Hello. A warm welcome to everyone. We have a very interesting panel discussion coming up today. The moderator of the panel discussion is our very own MC Patel, sir. The topic is negligence in ART practice and ART Act. Can I have the CVs, please? Dr. MC Patel, sir, as we all know, is a consultant gynecologist and
Shatabdi,
a
1
special
minute,
medical legal
and
counselor.
Shatabdi, 1 minute.
Yes, sir.
Padmavati madam joined. Please, madam, say hi to everyone and to MC Patel, sir. We introduced already, madam, in the second session.
Okay, ma'am. Okay, ma'am.
Okay, hi, madam. Hi, everyone, and Dr. MC Patel and everyone. Thank you.
Madam is the president of Bhimavaram Society.
Yeah.
Thank you,
Thank
madam.
you, one,
Thank
you,
for
one and all, and Dr. Radha Lakshmi for introducing me. Thank you.
Thank you, ma'am. Thank you for your kind words.
Welcome, madam.
Thank you.
Welcome.
Thank you, sir.
Yeah,
Sir, good evening, sir. Good evening, sir.
evening.
Sir, all the
Good
best,
evening.
sir, for you and
Yes,
Madam
thank
Lakshmi,
you.
madam, sir.
Thank you. Thank you.
Yeah.
Thank you, Padmavati, ma'am. Thank you, Radha Lakshmi, ma'am. So,
Dr.
MC Patel.
Shatabdi, sir has also been introduced in the starting of the program. You can start with the panelist.
Okay, ma'am. Okay. So we have 9 panelists with us today. Our first panelist is Dr. Karuna Kumari, ma'am. Can I have the CV, please?
Please.
Yes, ma'am is Associate Professor at Rangaraja Medical College at Kakinada. Is the Vice President of Oxy Kakinada, Andhra Pradesh, and has been invited as faculty and presented papers in various conferences. Welcome, Karuna Kumari, ma'am. Next CV, please. Our next panelist is Dr. Sama Sultana, ma'am. Ma'am is the chairwoman and co-founder of Hope-Wind Hospitals, Pradesh, as well as the scientific committee in charge of the Guntur Obstetrics and Gynecological Society. Welcome, Shama, ma'am. Our next panelist is Dr. V. Ramya, ma'am. Ma'am is a specialist in reproductive medicine and diploma in minimal access surgery. She has an expertise in advanced infertility treatment and currently is with Oasis Fertility. Welcome, ma'am. Next, we have with us. Next CV, please. We have with us. Ma'am has graduated from Rangaraya Medical College in Kakinada has been invited as faculty in many state and national conferences and started Rajamundri Obstetrics and Gynecological Society. Welcome, ma'am. Next CV, please. Next, we have with us Dr. Roshni, ma'am. Ma'am is a reproductive medicine and surgery specialist, currently affiliated with Sri Krishna Fertility Clinic at Eluru. A special area of interest is ovulation induction and fertility enhancing surgeries. Welcome, Roshni, ma'am. Next CV, please. Next, we have with us Dr. Gunapati Mithila, ma'am. Ma'am is the director of Mithri Fertinist at Nellore. She has a fellowship in diploma and diploma in minimal accessory surgery and has various publications to her credit. Welcome, ma'am. Next, we have with us Dr. T. Sri Lakshmi, ma'am. Ma'am has participated as faculty in various state conferences, presently the Vice President of NOXI and has been the past treasurer. Her special field of interest is high-risk obstetrics and infertility. Welcome, Sri Lakshmi, ma'am. Next, we have with us Dr. A. Sandhya, ma'am. Ma'am is the Chief Gynecologist and Obstetrician and Senior Laparoscopic Surgeon and Director of Arka IVF Center at Sri Kakulam, Andhra Pradesh. Welcome, ma'am. Next, we have with us my very good friend, Dr. Sri Harsha. Dr. Sri Harsha is the Clinical Director at Birth Health Fertility Center at Guntur. She's presented papers at various national and international conferences and also has been the winner of Dr. Jaideep Malhotra Yuva Oration in 2025. Welcome, Dr. Sri Harsha. Over to you, MC Patel, sir.
Thank you. Let me share my screen. So please stop sharing. I think Uma Shankar's screen is there. Uma Shankar?
Sir, not yet, sir.
No. This screen is already shared by Dr. Uma Shankar.
Oh, okay.
So you will have to
take it off. Yes, sir. Just let me.
Uma Shankar. Yes. Fine. But still, I do not see any button. Share my screen.
Yeah, am I audible to you?
Oh, yes.
Yes, ma'am.
I am unable to share my screen because no option is seen on my screen.
Okay. So one second.
I think there is something wrong on part of host.
Sir, move the cursor on the our mix panel.
Option is not seen.
Bring the cursor on the panels.
Dear sir, please share your presentation with me. I'll display it on the meeting.
No.
If you're not able to share,
in panel, it is not possible. It is to be managed by me only. So you should allow me to share my screen.
Sir, I have already given you the permission.
No, but here there is no option seen on my screen.
Okay, sir, please try now.
No, but it is not seen.
Okay.
Sir, once the cursor on the panels window.
But there should be
am I
either
audible to
panel
you?
or screen share. Nothing
I'm not
is
able
seen
to.
on my screen.
If once you bring the cursor on it, all the buttons are visible.
Not seen, madam. Only let me see again. Yes, now it is seen. Is it seen?
Yes, sir. Yes, sir. You have to make it full screen, sir. Sir, kindly make it full screen.
Yes. It is full screen? Hello. Is it full screen?
No, sir.
No.
No, sir.
Something wrong.
It has gone again, sir, now.
I have. Now?
Yes, sir. Yes, sir.
Now it is better, sir. Full screen. Yes.
Full screen?
Yes, sir. Yes, sir.
So it will be very introductory slide in the beginning, and then after it is reverse panel. So it will be open for all the panelists to ask any question related to ART Act, Surrogacy Act, and negligence related to ART practice. So that way we will go very quickly. So greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. And warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and all the president and secretary of joining society respectively for this webinar. I also thank you all stood with me during my last election, though I lost. But I believe in this. It was very nicely written by Shraddhe Atal Bihari Vajpayee. क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end but a new beginning. So journey to serve Foxy still continued with renewed patience. So again I will be seeking your blessings to endorse my candidature for post of President Foxy election year 2026, because still my commitment is there. Wherever you are, I'll be there. Promise to reach the unreached. So ART and Surrogacy Act. Why this ART Act? What was the necessity of this act? Was so ART has grown very rapidly during last few years. We all know, and highest ART center and number of cycle per year in India. But till then, there was no regulation, there was no guideline, except some guideline from ICMR. There was no protocol, etc. So this act came in existence, and now it is passed. Now it is no more a bill. Now it is ART Act, and all ART practice is governed by ART Act. So major center for global fertility industry over years, with reproductive medical tourism becoming significant activity in India. And despite so much activity in India, there was no standardization of protocol and reporting was inadequate. There were only guidelines on part of ART in ICMR, but there was no law. And objective of this act is to regulate ART services and protocol, women, children from exploitation, to support oocyte donor insurance cover for them, to provide rights of children, to regulate cryopreservation, to make pre-implantation genetic test mandatory when there is a family history in the same family as far as any inheritance disease are concerned, and to ensure proper registration of ART clinic and bank. So this is background as far as this ART Act is concerned. And now all the guidelines are given in ART Act, how to practice ART and not to end up into any kind of unethical and illegal practice, because there are stringent punishment provision also in this act. So with this, now it is open to you all to go for any question related to ART Act.
So what is ART Bank, sir?
ART Bank is meant for screening of donor, gamete donor, and they will screen and they will supply donor to ART clinic. And as far as screening of donor is concerned, it is the responsibility of bank, and they should strictly follow the criteria for donors also, age and some tests which are very much mandatory. Say for example, hepatitis B, hepatitis C, HIV, VDRL. So these are the mandatory tests to be advised to a donor. All other tests also you can go with routine, any other test, but these 4 tests are very much mandatory as far as ART Act is concerned, and bank is under obligation to go with all this. So screening with this, all this test, age, bank can verify as far as age part is concerned with Aadhaar card or any other ID proof as far as age part is concerned, because this is a very vulnerable part, because many a time person is minor but she looks like major, and she may come with a request that she volunteers for home donation, and many a time it may create problem in future. So bank should be very vigilant at the time of selection of donor, either sperm donor or ovum donor, or in case of surrogate also.
Thank you so much, sir. So what is the ART clinic? Can you throw some light
Yes.
on it?
So as far as all these ART procedures are concerned, whether it is IUI, that is level 1 clinic, or all other procedure related to ART, that is level 2 clinic, so it is ART clinic. And as far as surrogacy treatment part is concerned, center is to be registered as a surrogacy clinic. So whichever practice one wants to go, either level 1, that is up to IUI, all other procedure level 2 ART clinic, and if he is interested to go for surrogacy, then surrogacy clinic.
Sir, good evening, sir.
Welcome, welcome.
Sir, I have couple of questions.
Yes.
So it is being suggested that consents and agreements of the couple who are undergoing IVF or any ART treatment are actually given, the formats are given as in the ART Act,
Yes.
but is it it is suggested to be taken in the local language, so we have to take both consents. Is it like that?
So very important part is consent of all the party involved in ART program. Say for example, it is a donor program, then consent of donor, it will be taken of course by ART bank, and recipient naturally consent will be taken by ART clinic. There are prescribed form, consent form given in ART Act, but if at all you feel that still it is to be clear in a better way, you can have separate consent also, but that consent cannot replace consent to be taken as per prescribed by ART Act. So it is very much mandatory. One more thing, preferably it should be in a vernacular language or language patient can understand. But if it is not available, then if it is in English and patient doesn't know English, then at the end of that very consent, few lines should be written, preferably by patient, or even we can also write and patient can sign. Whatever written above was explained to me in language which I could understand, and all the question and all the queries were solved by a doctor, and then after I have given consent. So if she has given consent like this, then even if it is not in vernacular language, then also it will do. But it is always advisable to go for consent in vernacular language that patient understands.
So can I ask one more question, sir?
Oh yes.
Sir, in case of surrogacy, as we know, the couple should be married for 5 years for
Yes.
for considering to be an intended couple.
Yes.
So, in case of a true indication like MRK syndrome or some kind of indications where women doesn't have uterus, so should we wait for all the 5 years?
So very good comments and observation, because in my lecture usually I put this question. Okay, say for example, marriage life is of 18 years, and if it is proven infertility, then also she will have to wait for 5 years. Say, for example, if it is absent uterus or gross uterine anomaly, in which pregnancy in other way is not possible, and if at all they have to go for either surrogacy program or any other program. But as far as provision of law is concerned, naturally we will have to wait for that. But there is option. In this situation, they may approach Honorable High Court seeking writ petition for request that it is proven infertility and we do not want to wait for 5 years. Please allow us to enter into ART program. And if court is kind enough to allow, then one can enter in the ART program.
Sure. Can you throw some light on the embryo disposal or renewal system, sir? Is it
Yes.
dependent on the individual hospital's renewal policy? If
No.
at all, if the renewal
No,
is
there is strict provision in ART. So at the time of taking consent, couple will give consent that in case of disposal of this embryo, say for example in event of death of husband or judicial separation or divorce during this procedure before it is transferred, then there is a provision. They have to give option. Either they want to get it Paris, either they want to get give those embryo for research purpose to research institution, or if husband has given consent, then in event of my death, this embryo can be, or this ovum even, or in this gametes also can be given to my wife, then all this can be given to wife. Same way wife can also give consent. In event of my death, it is to be given to my husband. But very tragic situation, if at all embryos are formed and before transfer, death of both husband and wife. In this situation, what should be done? Because many a time it may happen that there could be claim on part of father of husband or parents of husband, same way parents of wife. So in this situation, whom embryo can be given? So again, at the time of taking consent, it should be clarified that in event of unforeseen death of both, can this embryo be given to parents of husband or parents of wife? Then only this embryo can be used. Otherwise, this embryo is to be disposed of. But at the same time, ART clinic will inform National Registry and appropriate authority, local appropriate authority, that this have happened and please allow us to perish this embryo.
Sir, I am actually asking about the renewal failure, which means our hospital has supposedly has the renewal policy for every year, the embryos,
Yes.
and X amount is charged for
Yeah,
renewing the
fine,
embryos.
got your point. Got your point. So
So,
again, at the time of taking consent, because when they are going to go for preservation, cryopreservation, then it is for 10 years as per ART Act. And if at all they want to preserve for more than 10 years, again they will have to approach National Registry, and with permission of National Registry only we can preserve this embryo for more than 10 years. But for the same, they will have to pay charges of preservation. And in this act, there is a provision. If they fail to pay charge for renewal of this preservation for one more year, then at the time of taking consent, it should be clarified that clinic will be free to allow embryo to perish, or clinic will be free to give those embryo to research institution for research purposes. But at the time of taking consent, this also should be clarified, and proper consent from recipient, I mean this intending couple, should be there in this type of situation if at all it happens.
how long should we wait? Supposedly they should pay this month, but they are not paying for 1 year or 6 months.
That is also to be mentioned at the time of taking consent, that in any event of failure of charge, as far as preservation is concerned. How far clinic will wait? Say, for example, if it is mentioned that 6 months, then naturally you will have to wait for 6 months. And after 6 months again, in good faith of that very couple, you can summon one more notice that you have failed to deposit the amount, and now we are going to destroy this embryo. So everything should be clarified at the time of taking consent, not to end up into any kind of ambiguity.
So that is dependent on the hospital's policy, which they have
Naturally,
given
then
consent.
of course hospital policy, but being a medical legal consultant, I always advise to our hospital which we are looking after as far as medical legal part is concerned, that it should be clarified at the time of taking consent, because these are the possibilities. Of course, if intending couple is interested, then naturally they will pay. But for some reason, they are unable to pay. So in this type of situation, clinic is in a very awkward position. So they will have to act accordingly as per consent given by couple.
Thank
So
you.
at the time of, sir?
Yes.
So at the time of starting of the IVF treatment only, we had to take the consent regarding the freezing and discard also.
Naturally, but if they are interested to go for preservation, then naturally we have to go for consent. And in this situation, if they have given consent like this, then we can have to act accordingly. So counseling is very important part in not only ART practice, in all practice, but in ART practice, as far as this preservation part is concerned, we have to mention that also.
Sir, regarding the donors, oocyte donors, we have to do health insurance for them, but nowhere it's the particular amount is being prescribed, like how much amount we have to do the insurance, health insurance for them. Is there any particular the amount we have to do?
Amount, you are absolutely right. There is no amount fixed in ART anywhere. But as far as insurance part is concerned, for donor or in case of surrogacy program for surrogate, it is a responsibility of intending couple. We know. So if they have fixed any amount, say for example, they have taken insurance of 50 lakhs, and for any reason expense exceed that amount, recipient couple is under obligation for the expense incurred for treatment of donor. So a recipient couple, I mean this intending couple, should think how much insurance they should go with. So there is no law. It is at discretion of intending couple. If they want to take risk, then they can go with smaller amount also. But they are under obligation as far as treatment part of donor and surrogate is concerned.
So for 2 years, they have to take the responsibility of the donor.
For 1 year for donor and for 3 years for surrogate.
Okay. Sir, if the intending couple brings some donor, we can recruit them, sir, from the ART bank, we can recruit the donor like known person.
Now it is allowed. Now it is allowed, but screening will be by ART bank. And once ART bank gives the certificate that she is eligible donor, then only we can entertain.
Sir, one more thing, sir. For the couples who are married at age of 18 years, and when they came for the screening, a husband came to be as azoospermia. Then they have to go for donor IUI. We need to wait till like 21 years, or we can proceed.
We discussed in the beginning only. So in this situation, as such, you will have to wait as per provision of ART Act. But in this situation, they can approach Honorable High Court seeking writ petition, and many a time High Courts are very kind to allow them to go for ART program. But they will have to prove by all this investigation report, etc., and certificate from appropriate authority that it is proven infertility, is absolute azoospermic, and he will need a donor program in this particular situation. and court will usually permit in this situation. But straightway you cannot entertain them unless there is permission of court till they attains the age of eligibility as far as ART program, donor program is concerned.
Thank you, sir.
Yes.
Good evening.
Good evening. Welcome.
Cryopreservation of embryos, sir. So if we take a particular time, like we'll discard the embryos if you're not responding within 3 years from the date of freezing. And even then, even after repeated intimation to the intending couple regarding their cryopreserved embryos, if they are not responding, can we discard them or will we
Yes,
be liable?
because you have given enough time to them to respond, and even they have not responded. But word of caution I would like to advise, you please serve them a notice with register ID post or any other means you can prove that you had served a notice that you have not responded as far as preservation of this embryo are concerned. We are going to allow them perish or we are going to destroy them on this particular date. Before that, if you are interested, please approach our clinic and do needful. And even they do not turn up, then you are free to go accordingly.
Sir, one more doubt, sir. Regarding if we have to, for a particular place, we have registered under level 2 clinic and we are planning to shift to a new building. So we have to take a new ART clinic registration.
So in PCPNDT Act, there is a provision. If at all there is a change of ownership, change of place, change of employee, change of instrument, then you have to simply intimate appropriate authority. I am talking of PCPNDT. But in ART, it is not clarified that if there is a change of place, change of ownership, change of equipment, or change of employee, will it be done only with intimation or one will have to go with fresh formality of registration, etc. So it depends upon the discretion of appropriate authority of that particular district, how they interpret in this type of situation. So we will have to approach naturally appropriate authority that we have shifted from this address to this address. Please allow us to practice and please issue us the registration of certificate. I mean certificate of registration.
Sir, regarding patient files, sir, what we have to do with the patient files? Can we ship them to the new building or?
No. As far as ART Act's provisions are concerned, if you have cryopreserved their embryo, etc., that embryo cannot be shifted to any other clinic, even if patient gives consent. In this situation, you will have to seek permission from National Registry. So National Registry will allow you to transfer those embryo from your clinic, one clinic to another clinic. National Registry.
Even if it's under same name, only change of place is there, then also we have to intimate the National Registry.
Yes. National Registry is under power for this. It is incurred with power to give permission.
Even if there is merger of some clinic to the other, then also we need permission for.
If there is change of ownership, if there is change of name, in all this situation, it is always better to inform National Registry to transfer embryo from one place to another place.
Sir,
If
there
it
is no
if it is in the same premises, say for example in the same building, but there is a change of ownership or change of name of clinic, then also National Registry is to be informed.
Sir, even without any change in the name of the clinic or ownership, also we have to inform to National Registry, sir.
If you have to transfer embryo from one clinic to another clinic, say for example, patient is with me for treatment and I have their embryo preserved. They are not satisfied with my treatment and they are interested to come to you, Dr. Rosni madam. Then also, even if patient is willing to transfer embryo to your clinic, we will have to take permission from National Registry. Willingness on part of patient is not enough in this situation.
Sir, only the change of address, sir. Like we are
Pardon?
changing only the change of address, sir. The ownership is same, the doctor is same. Only the address, like one premises to we are changing to other premises also, we need to inform, sir.
Yes, naturally, we will have to intimate appropriate authority for any change of address, change of employee, change of instrument, change of this ownership, and usually appropriate authority, of course, they take some time, but they will permit.
Okay, sir. Thank you, sir.
Yes.
So after 10 years and when we have changed to one more place and we have kept our registration the same, after 10 years, if we are not planning to continue in the old place, we have to submit all the data to the central database and
Yes,
then
yes.
we
So
can start
it is
MCOs, sir.
provision of ART Act that you will have to preserve record till 10 years, and after 10 years, all the record are to be transferred to National Registry. In closure of your hospital early than 10 years, many a time it may happen that you are closing your clinic at 6 years or 7 years or so, then also you will have to transfer all those records to National Registry. One more area, in case of litigation, if litigation is pending beyond 10 years of time, then you can have all this record with you. But in this situation also, you will intimate National Registry. Their case is pending and we are keeping all this record till final disposal of that very case. Yes,
Sir,
madam.
Good
Yes.
evening, sir.
Good evening.
Sir, I have one question. When we are recruiting donors, like the stimulation can be done by the donor banks and we can retrieve the oocytes, or should the stimulation be done only by us after recruiting the
No,
donor?
stimulation can only be done by ART clinic.
ART clinic,
Either
not by
level 1 or
the.
level 2, whichever the program. Say, for example, if it is IUI, then level 1. And if it is any other procedure, then level 2. But ART bank has no power or comfort to go for stimulation program. They
So
have
legally, only the level 2 clinic only should do the stimulation.
screening and supply.
Okay, okay. Sir, one more patient, few of the patients will ask us, no, sir, regarding whether they can use their own relatives as the donor.
Yes, now it is allowed. Now it is allowed, but screening and
And
everything by
age
ART
also,
bank.
sir, below 33, 35, we need to recruit the same way, or?
Yeah, even if donor is known, then also they should approach ART bank. ART bank will screen that very donor by all criteria, age, all the tests, physical fitness, etc. And if ART bank is satisfied with all the criteria fulfilled, then only ART bank will supply that donor, of course known, to ART clinic for further procedure.
Okay, this applies for both the donor oocyte and the donor sperm, both the
Yes.
parties.
Yes. Even if they are known, then also it is through ART bank only. Straightway ART clinic cannot entertain.
Sir, altruistic surrogate, once we are transferring an embryo and it has, it ended up in a miscarriage, then again we can go with the same surrogate. That's not a problem, right, sir?
Yes, yes.
Okay.
But in live pregnancy and delivery, only once in a lifetime.
But like this, like
But
how many
if cycle is failed, and if surrogate is prepared to go for second try, then we can go. But even in that also, somewhere I had read, I am not sure, but you can go for only 3 try and not more than 3.
Not more than 3.
Sir,
Yes, yes, madam.
sir, I have a doubt.
if
Yes.
a stimulation, ovulation induction is done by a level 1 ART clinic for
Yes.
IUI purpose, but she landed up having multiple follicles, can she be shifted to level 2 clinic, and who will perform retrieval in level 2 clinic?
So if she is shifted to level 2 clinic, at level 2 clinic, she can be taken care of, no issue. But person who have stimulated at level 1, if his or her name has already been entered in level 2 clinic, then only she can. Otherwise, she cannot do that procedure at level 2 clinic. Got the point?
Yes,
Say
sir.
for
Yes.
example, say for level 1 or level 2, whosoever is going to work or working in that very clinic, names of that consultant should be there with appropriate authority. So if person who has stimulated at level 1, his or her name is not at level 2 clinic, he or she cannot enter in that very procedure.
Can
So
we go
level,
ahead with retrieval with the
oh yes, you can attend, everything is fine, but procedure will only be done by person who is
who is
enrolled
registered?
at level 2 clinic.
Okay. Okay. Thank you.
Sir, what is the age limit to avail ART services, sir?
Now it is clear that in case of male, it is 23 to 55. And in case of female, it is 23 and 50. So not more than 50 in case of female, not more than 55 in case of male. At the day of transfer, when transfer is being done, their age should not be more than 50 or 55 respectively.
What are the criteria for donor eggs?
Same as far as donor part is concerned, there also there is age limit is there, and all the tests, say for example HIV, HBs, AG, that is hepatitis B, hepatitis C, VDRL, they should be normal. All other criteria should be normal as far as their physical fitness is concerned. Age part is also as per ART Act, and then ART Bank can allow them to go for donor program.
So can we recruit the donors from the other places? Like, for example, like in Andhra, we are having a fertility center. Can we get the donors from other places, like
Yes,
from other
all over
ART
India,
banks?
from anywhere.
Then the donor has to come and stay at our place for the stimulation. The 10 days she has to stay here. We have to take like that accordingly.
Because as far as her health part is concerned, you are responsible. So naturally, you will think for that also. No?
Okay. Sir, for the donor, only the donor is adult according to her Aadhaar, and she has matched the age limit. Is that mandatory to take the consent from the husband also, or consent is enough?
Nani, as far as donor program is concerned, a signature of spouse is very much must if they are married.
Okay, only if the husband accepts, then we have to take it. Husband consent is mandatory.
Yes, but if say for example, unmarried male is interested to go for sperm donation, so in this situation, naturally he will give her his consent.
For the
And
donor egg,
donor egg also.
okay.
If she is married, then consent of husband is very much mandatory. Because, say for example, one more situation. She is married, but there is a petition for divorce, and still decree of divorce is not done, and she is interested to go for donor program. Unless signature of husband is given, she cannot enter in donor program.
So likewise for surrogate
Till
also.
final decision from court, in eye of law, she is married. She is not divorcee. And that is why signature of husband is must.
Likewise for surrogate also, she needs surrogate mother needs consent from husband, sir, to be a surrogate.
naturally.
But the law doesn't mention about the signature of the.
Many, as far as consent is mentioned, in that very consent, first line is all the party involved in ART program should sign the document. So consent is to be taken by all the parties. Say, for example, recipient couple, husband and wife, surrogate and her husband.
Okay.
Because without consent of husband, one cannot be surrogate. If all other criteria are very much fulfilled, then also consent of husband, because there will be contract between recipient couple and surrogate couple. And that very contract should be signed by all the four party involved. Because in this type, being a medical legal expert, we go with this type of contract. In this situation, I counsel both the couple separately and together. First, I will call recipient couple. I will discuss with them what is their legal responsibility and what is their legal right as far as this surrogate program is concerned. And same way, I will counsel surrogate couple. And then after understanding everything, if they are willing to enter into program, then we will go with surrogate agreement. And that surrogate agreement will be signed by all the party involved, and it will be affidavit before notary.
So these cases we are hearing like a lot. Some donors are coming and giving us affidavit. They are telling this is the first time they are donating, but they are donating at multiple places all over India, and they are just hiding the truth. Then how far the bank or ART clinic is responsible for that? Once the donor has given that she is donating for the first time.
Not at all responsible, but at the time of taking him or her as a donor, and at the time of taking consent, she will mention in that very consent form only that it is my first donation. I have never donated anywhere else in past. So if information is given by that very patient is false, then that is up to him or her. How one can prove that she is going to go for this donor program very first time. But when national registry will be functioning full-fledged, then after this problem will be solved, because it will be totally pan-India. And once you enter record of that very donor who is interested to go for donor program, and if at all she or he has donated somewhere else, it will be seen on screen.
Yes, sir. Sir, regarding the sperm donors also, the known person can be taken.
For sperm donor, it is not like that. It is for
No. Known person. I'm asking like.
Yes.
We can
Now
take.
it is. But again, word of caution, because it may create social problem in future. Because once he gives a consent, in that very consent, he will write that also. I waive all my rights from the child to be born with this procedure. So he will go like this, and at the same time, recipient couple will go like this. After this donor program, a child to be born with this donor program will not claim any property or anything from donor if they are known particularly. So this type of word of caution should be there at the time of taking consent, because many times what happens in future, they claim this is my biological child and now I want custody of that very child. So not to end up into this type of problem at the time of taking consent with this donor, it should be clarified well in advance.
Supposedly, there is a scenario.
For patients while doing ART, can we do video counseling?
Yes, we can. It is valid evidence in court of law.
Sir, supposedly.
But before you go with video consent, one will identify by their own. Say, for example, I am Dr. MC Patel. See Dr. Harsha. That way they will identify, and then you will start your video counseling.
We have to introduce ourselves.
Yes, naturally.
Sir, supposedly there is a scenario where couple husband is works abroad, and he comes for an IVF procedure along with wife, and we have done the initial embryo transfer after oocyte retrieval, for which he was there, and he left. Initial transfer was negative, and patient's wife wanted one more transfer with the remaining embryos. So this time husband is not there. So can we go ahead with the transfer, or do we need a consent in again? And in case of his absence, can we take some consent through mail or something else?
So consent of husband is very much must. So at the time of counseling and at the time of taking consent, if they have specifically mentioned that if first try is failed and if I am not available in India, then I give my consent to my wife to go for second try, third try, fourth try, whichever. Then it's fine. Otherwise, wherever he is there, he can send consent from there also, but there should be affidavit there where he lives. Then it will be considered as a valid consent. Mere consent that I give my consent will not be sufficient, because many a time it may create problem. I had never given a consent, or it could be fake, because whenever patient produces that consent to you, we never know whether it is from her husband or she have made this fake consent. So it is always better whenever you get this type of consent, when husband is not present before you, then it should be affidavit from husband where he stays in other country also.
The thawing of embryos and culturing from day 3 to day 5 need a specific consent from any of the partners.
No. This is procedure. So when we take consent, it is prescribed consent in ERT Act also. How we are going to go for, it will be a stage of stimulation, then ovulation, then ovum pickup, then ovum and sperm in that very dish, then fertilization, then embryo formation and transfer. So we have mentioned everything at the time of counseling and in at the time of taking consent in the beginning. So it is well explained at that point of time. So no need to go for every time as far as this day third or day 5 or whichever.
No, I have a situation at my own hospital. So the patient's embryos were frozen in on day 3, and the wife was actually not in good health, as we know from her medical conditions. But the husband has requested, when the time of renewal has come, I mean, they didn't undergo transfer of a couple of months. Again, the renewal time has come. This time, the husband has come and he requested that we will renew the amount only if the embryos are viable. So thaw from day 3 to day 5 and see if they are surviving, and then only we'll pay the renewal amount. That is the situation. So when he requested, we have thawed the embryos. But the wife later on, and 1 or 2 embryos have survived, which I have frozen on day 5. But the record which was given to the wife and husband initially is indicating X number of embryos. Day 3 embryos are obviously more in number. Again, the day 5 have generated another report with less number, right? So this time the wife has come and claimed that we two are separated, we're not living together, and why did you thaw my embryos without her knowledge? So this is a scenario.
So again, I mentioned prior also, at the time of taking consent, it should be clarified. In event of unforeseen dispute between us, then what should be done as far as this preservation of embryo is concerned? So it should be clarified at that point of time. Otherwise, it becomes very difficult, and naturally it will become a court matter, because it is a property of both. One cannot claim for that very embryo, and you are custodian only. ART clinic is custodian. So you cannot take judgment, or you cannot entertain anybody. You have to strictly follow willingness on part of both. If they both are not agreed to go accordingly, then you cannot go. Let them fight in court. Let the have an order from court, and as per order from court, you will do accordingly.
So for as a matter of safety, any procedure or any manipulation should be done only with the consent of both the partners.
Naturally, all the party involved in ART program should sign the document is the dictum in ART Act. But at the time of counseling, in very first beginning only, all these points should be there in your consent paper. Whether it is consent or not in that particular case, you can delete. But not to miss any important point, your consent form should be there with all this detail. In event of this, in event of this, in event of this, what to do. And if you have taken that consent, it will be easier for you also to do accordingly.
So for commissioning couple underwent treatment with us, and they got separated after preserving their embryos with us. So what we have to do with those embryos? Can we discard after taking consent from them?
So in prescribed consent form, it is mentioned 3 options. It is given that embryo should be given to my wife, embryo should allow to perish, and embryo can be given to research institution for investigation, I mean research purpose. Same way wife will also give consent. So which type of consent they have given at the time of counseling and consent, you have to act accordingly.
So we can take, we have to take consent from both wife and husband even after divorce.
Both. Just I mentioned, because if at all embryo is to be formed, then it is property of both. So one cannot claim. So we should be very clear at the time of taking consent. So wife will also give consent. It can be given to my husband, or it is to be allowed to perish, or it is to be given to research institution. Same way, husband will also give consent. It can be given to my wife. And if they have given consent like this, then you can act accordingly.
Sir, if we take consent, while taking consent itself, if we take from them that if we both got separated, we can allow the embryo to perish. Can we do like that, sir? Then?
Naturally, because just I mentioned prior also, it is property of both of them. And if both agree to allow those embryo to perish, then naturally we have to. But in this situation, you will inform National Registry also that we had embryo of this couple, and now there is a judicial separation or dispute between them, and they are not willing to continue with this program further, and they are willing to allow embryo to perish, and we are doing that. So National Registry will have to inform.
Should we submit the separation thing also, sir, or just we can submit the consent that is enough for National Registry, Central Database?
Simply inform.
Simply inform.
The couple is not willing to continue with this program now, and they are willing to allow embryo to perish, and we are going to go for that.
Thank you, sir.
Yes.
Sir, regarding the donor oocyte, sir, the intending couple, one affidavit we have to take, and along also from the donor we have to take one affidavit, sir.
No. Affidavit for insurance is from recipient couple only.
Insurance, okay, sir. And affidavit that the donor is giving willingly and she's been giving the first time, like that, we have to take the affidavit from the donor.
This is abundant caution to be on safer side, that she was not forced, she was major, that way all the criteria.
Yeah, all with the consent of husband she's giving, and she's having kids and so on. So we will be adding.
She will give consent like this, that with consent of husband, but signature of husband is must.
Husband should be married.
She may go live also.
Yeah, fine. And from the intending couple, the affidavit is mandatory or just insurance is enough, sir?
Any insurance, but affidavit also.
Affidavit that they are taking the
because say for example, just we had a discussion beginning also, if insurance of some X amount and expense exceed that X amount, In this situation, there will be a problem. So affidavit is there that we have taken insurance for that donor, and we are duty bound to take care of her health as far as any problem related to home donation program is concerned. So they are duty bound to go for any expense, even beyond expense of insurance amount.
Sir, if the couple is not willing to give their names in the affidavit or something, we can just keep the Aadhaar number, sir.
Not give willing
I
to
mean,
give.
they don't want to display their name in the affidavit.
No.
They have.
Affidavit go with the identity only. Because in that very they will have to stick their photo also.
Yes.
So without name.
So that affidavit, the clinic, ART clinic and the blank has to maintain that affidavit that from the intending couple. For the
Naturally, that
documentation.
original copy even they can have, but we should have at least copy.
Copy. We have to maintain the documentation.
It's always better that original copy should be with clinic.
Okay.
Clinic or bank, whichever the case may be.
Okay, sir.
Sir, can you tell about sex selection provisions? Means in which cases?
No. No. There is a stringent punishment provision. If at all it is caught that there was sex selection before transfer, and there is a provision of somewhere 5 to 10 years of imprisonment and some 10 lakhs of fine.
If they ask like some sex-linked disorder is there or diseases are there.
That is different. There is exception. If there is a sex-linked disease or any disease goes in hereditary, then it's a different story. Otherwise, one can.
Okay.
These
To
are
prevent
exceptions given
some
by law.
disorders and all, there is a
So
provision to check.
these are exceptions given by law also.
Yeah. Okay, sir.
Thank you.
Thank you, sir.
Thank you, sir. All the best, sir.
Thank you.
Thank you, sir. All the best, sir.
Yes,
Sir, one
thank you.
doubt, sir. In many of the social media, some of the doctors are practicing in Dubai. They are giving advertisement. Come over to Dubai or something like that. We do induction and we do sex selection. We give so and so sex baby. Can they do in our country like that, sir?
They in their country, if the law is
But
not that.
we are seeing in social media some of the doctors giving
No, it's real,
advertisement.
ma'am. I myself have done induction here in India,
Mm.
and they went there and had egg pickup and embryo transfer in 2 different months. It is some 15 lakhs package.
So for the sake of sex selection.
Yes. They wanted a male boy, so they went. Altogether, they had 20 lakhs expenses.
So in that very country, if there is no act like it is prevailing in India, they can entertain patient their way. But as far as practice in India is concerned, we in ART Act, Indian government and Indian law are very clear that we cannot entertain preconceptional sex selection, we cannot entertain prenatal sex determination, and we cannot entertain this type of advertisement for our clinic in any newspaper or any other media. It is very clearly mentioned in ART Act, and there is a stringent punishment for the same.
So one more question, sir. We are not having any degree in reproductive medicine, sir. So we can run ART clinic level 1, sir. Can we register ourselves in level 2 clinic and do induction in ART level 1, or can we do in level 2 clinic and do ovum pickup in level 2 clinic with the help of a ART specialist there?
So it is very clear, whichever practice you are going to go or you are willing to go, your center should be registered accordingly.
No, sir. We are not having. We are having only ART clinic level 1, but we can register our name in level 2 clinic, do induction of ovulation there, and also pick up there.
So if your name is registered with any ART clinic level 2, then you can stimulate that very patient at your place. and you can do procedure in level 2 because your name is already there. You are enrolled.
Okay.
Sir, is there provision of adding the doctors at the usually we register the doctors at the time of inspection and ART permissions. Is there any provision to add another doctor later?
Yes. Say for example, today I am visiting consultant at your place and I give you a notice. From next day, I am not going to give my services to your center. What will you do? Naturally, you will have to invite one more. Other than that, you can invite n number of doctors in your clinic. You will have to simply intimate appropriate authority. Dr. So-and-so is working or is going to work in my clinic. You will have to give all the details of that very consultant. Name, degree, his experience, mobile number, email ID, address, etc. So if that very person fits in criteria, then appropriate authority will allow.
Okay. So we need to apply like the new addition of new doctor
As such,
to.
it is not application, it is intimation.
Okay,
You will have to
intimation.
intimate appropriate authority ke following doctors are going to work as a consultant in our clinic and they should fulfill all the criteria.
So
Once we got the.
can a
Please
doctor
continue.
having a degree in reproductive medicine, can they run multiple centers in multiple areas in their name?
Yes.
So, okay, sir. So we can add our name in their center as a consultant. Okay.
Yes.
So in our practice, most of the times a patient comes for us with 1 year of even less than 1 year of duration of marriage for infertility treatment. As such, you told at least minimum 5 years of the with the normal male factors and female factors. In such a case, how to deal the cases?
5 years is not criteria from marriage. It is age. Say for example, 23 years is the age, minimum age required for female person to go for ART program.
Okay.
And her allowed marriage age
So
is 18.
duration of marriage is not. So even with the 6 months of marriage, if they want to go for ART,
And even with 6 months of marriage, if she is more than 23 or then they can. But usually we advise them to wait for at least 1 year or so. If there is no major issue, we can investigate them. We can advise them. But in few of the cases, you will have you have experience also that couple are very keen to go for issue and they will insist you to investigate them. They are not ready to wait for more period. So in this situation, if age is no bar, if other criteria are no bar, then you can entertain them.
So
Only for surrogacy, we need to wait for 5 years, ma'am. Only for surrogacy.
So if a patient undergoes ovulation induction and she had 3 or 4 embryos or 3 or 4 ova, which they were freezed, sir, and they conceived in the first cycle, there will be remaining 2 or 3 ova or 2 or 3 embryos remaining. Can they, with their permission, can it be used for other their relatives or with the reproductive medicine specialist with the consent of the couple, can they use that embryo bar gamete for other person, for other infertile people?
So again, it becomes a ovum donation program.
Yes, sir. So most of the infertility specialists are doing like that only, sir.
Agreed, but it is ovum donation or embryo donation?
Yes, sir. Sir, they are doing both, sir. Ovum donation, embryo donation, both they are doing. With or without the consent of the
because in
fertile
past,
couple in most of the centers in our Kurnool.
So in any, not in Kurnool, all over India. But in past, it was practice that they, at the time of taking consent, they were convincing a couple that if with 1 or 2 try, a patient is pregnant, so all other embryo, gametes, can it be given to another couple for money? Because at that time, this commercial
Not money, sir.
was not.
Not
I am talking of past. So in this type of situation, to curtail expense, many a times couple was also willing
Yes, sir.
to go for this type of program for money. But now with this newer act, AIT Act 21 and amendment in 22, so now commercial surrogacy is totally banned. So if they are willing to give that very ovum to any other relative free of cost, that is altruistic, then it's fine. Otherwise, if at all something goes with any financial transaction, then it becomes very difficult for any clinic
They say
or
as free of cost only, sir. They
Yeah.
So
say.
even the donor, we can use, sir, like donor program, we can take that oocytes or embryos. No.
But at the time of taking consent, in the beginning, it should be clarified.
No, no, sir. Like the excess embryos, ma'am is asking. That couple has completed their family and they're not willing for the any more children. You can donate that oocyte or
But
embryo.
at the time of counseling, very first time, it should be clarified that what should be done with that
Excess.
reserved excess ovum. So there are three possibilities given in that very situation. It can be given to my husband, it can be given to my wife, whichever way. It can be allowed to perish, and it can be given to research purposes. There is no other option.
Ah.
It is newer act. Whichever we were discussing, it was for past. So
That's the
now
past.
with this newer, it cannot be done. It should not be done, because if at all it has come to it comes to notice of appropriate authority, and if case is filed, it will be very difficult for that very clinic to get rid of this legal consequences.
Only with the consent of couple, we need to discard the embryo if they don't want. That's it.
One can discard, one can give to research purpose in research
Yeah,
institution,
only two
or
options.
give to survivor, husband or wife, whichever.
Okay, sir.
Sir, one more question, sir. Good evening, sir.
Good
Sir,
evening.
in the consent regarding the IUI, sir, if the husband is couple is going for the donor IUI, so when we take consent once from the couple, is it enough, or every time when we are doing the IUI cycle with donor, we have to every time we have to take the consent?
It is allowed, but at the time of taking consent, we will have to mention, to be on safer side, if this cycle fails, then we give consent for another cycle also.
Okay, sir. That we have to
But
mention.
many a time
Otherwise, we
what
have to
happens,
take every.
many a time it is likely that if first cycle fails, patient will insist you without knowledge of her husband, you please go with IUI with donor. This type of practice never entertained, because if at all husband is not informed for second try, then it will be difficult for us to face in court of law if at all husband has filed
They
a
have
complaint.
given once the consent, and next for the next month he left the place and he went to abroad, and that cycle failed. And when I explained them, he is saying that I have already given consent for the donor. Why you are asking again and again?
That I mentioned at the time of
So we
taking
have
consent in the
okay.
beginning. If he has given consent like this, if first cycle fails, I give my consent to go for successive cycle for IUI with donor. Then it's
Okay.
fine.
Okay, sir. Thank you, sir.
So I think we have justified the time given to us for reverse panel. Radha, is it okay?
So, yes, sir. Yes, sir.
Yes.
Thank you,
If
sir.
any question from anybody, any delegates even, if they can put question in chat box, we will entertain. So before we conclude, let us
Thank
see.
you, sir. Wonderfully, you have answered all the questions, sir.
Is there any question in chat box?
No,
No, sir.
No, no? Then it's fine.
Also offers various.
So thank you all for your good question, I would say, in panel, making panel very interesting. And again, before I conclude, it is my humble appeal to endorse my candidature. All the president and secretary first, they will nominate my candidature in last week of April or first week of May. You will get a communication from Foxy. First, you will nominate my candidature, and then in month of August 1st to 10, you will have to vote and make others also to vote for me. Same way for Radha, you will have to nominate her candidature for post of chairperson, ethics and medical legal committee. And at the time of voting in month of August 15 to 25, you will have to vote and makes other also to vote for her.
Thank you, one and all. I request to Monica to tell the.
Sir, all the very best, sir, to you, sir, and Radhalakshmi madam.
Thank you, sir. Thank you, sir.
Thank you, Eluru, Guntur, Kakainara, Nellore, Rajamundry, and Srikakulam societies for joining us today for this insightful webinar on infertility. We also thank our coordinator, Dr. Radhalakshmi Madam, Dr. Monica Gupta, Dr. Deepika Lugane, Dr. Shatabdi De, Dr. Nivedita Datta, and Dr. Megha Kamlapurkar. It was a privilege to have Dr. Yashodhara Madam, Dr. Ramarao Sir, and Dr. Nirmala Devi Ma'am as our guest of honor for today. Our speakers, Dr. Ruma Shankar Sir and Dr. Lalita Disha and Dr. Lalita Kampati. Our chairpersons, Dr. Padma, Dr. Pandula Revati Madam, Dr. Aruna Kumari Madam, Dr. Anurag May Ma'am, Dr. Padmavati, Dr. Sunitha Ma'am, Dr. Venkat Rao Sir, Dr. Satyavati Ma'am, and Dr. Vijayalakshmi Ma'am for chairing the sessions. Our moderator, Dr. MC Patel Sir, and our panelists, Dr. Karuna Kumari, Dr. Shama Sultana, Dr. Ramya Swati, Dr. Roshni, Dr. Gunapati, Dr. Sri Lakshmi, Dr. Sandhya, and Dr. Sri Harsha. We also thank Corona Remedies for the technical help and the academic platform. Last but not the least, requesting all of you to please support Sir's candidature for the presidential candidate and Dr. Radhalakshmi Madam for the Medical Legal and Ethics Committee, FOXY. Thank you so much for joining us today. We will be also sharing the recording shortly. See you again in the next webinar on the next Tuesday.
Thank you. Thank you, one and all.
Thank you.
Thank you, ma'am.
All the best, Radha ma'am.
Thank you.